what they need. Happens every time you get out hypovolemic, you get dehydrated, all that. This kicks in. Now, we went through I could go through a whole long 4-hour explanation, but they send out renin. Mm-hmm. Renin gets converted to angiotensin 1. It's done by chemical neurotransmitters, norepinephrine, stuff in the brain. Don't worry about it. You get your angiotensin 1. It circulates back to the lungs. Because again, where does the circulation happen, right? All right, so it's like a circle. All right, so gets to the lungs. You have something called the angiotensin converting enzyme. Okay, that converting enzyme is something that's in there because you inhaled it. It's like in the air or something. All right, all that does is converts angiotensin 1 to angiotensin 2. And then, not really, we're circling back around the kidneys, but it stimulates the production of another something happens. You get the stimulation of production of aldosterone. Okay, all I want you to know is the end result. It responds to shock. So what do you think it's going to try to do? All right, if you're out working outside and you're dehydrated in the middle of summer in Texas, have you ever worked outside for a long time or been doing a sports event or something like that, and you're like, man, when was the last time I peed? Mm-hmm. Because that's what happens. You get sodium retention. One of the things that happens, you get sodium retention. Where does water follow? Sodium. So it's going to try to hold on as much fluid as it can to keep the volume up. Does that make sense? You won't be pissing 10 times out in the middle of summer and you hadn't drank anything, because what's going to happen? You're going to get more dehydrated. This is what happens to DKA patients. They get real dehydrated because they just keep peeing because they're trying to get rid of all that excess. It's their buffer system trying to get rid of excess acidosis. Okay? The other thing that happens is you get vasoconstriction. These are the two end results. And the deal is to try to keep the pressure up, try to keep the volume up in response to shock, right? This kills CHF. What does CHF not like? Excessive pressure and excessive volume, right? They have to shut the RAS system down. But I'll show you that here in a second with the medications. But I want you to understand, this is, in a long explanation, this is the whole end result of the RAS system. Is try to hold on to volume, hold on to pressure. Because I want you to understand what the kidneys do is they control pressure and volume. Pressure and volume. All right? It'll play into, when we talk about preeclampsia, it'll play into CHF. It'll play into a lot of other things. So I want you to keep that in mind, just to understand how the system works. Okay. Another big deal in natural registry is they will give you a medication. They will give you a medication and say, hey, what's wrong with it? Now, they can't give you a medication if it's not for sure used to treat this deal. It has to tie into it one-to-one. Or they might give you medication and say, hey, what does this do? Now, to me, these are the most common deals. I've seen these over and over on natural registry, and people have come back. All right. These two are simple, or these three are simple. What do they have? They take this, and it's a one-line question. They have this. What do they have? Lithium.
Bipolar.
Everybody that is bipolar takes lithium. Mm-hmm. So lock that in your head. They may have a whole range of other medicines, but their baseline treatment is lithium. One of their baseline medications is lithium. Yes. So like if you're running on a patient and you see lithium, it's not because they have depression, they have bipolar. They've been diagnosed with bipolar. So if you see lithium, you know you're dealing with a bipolar patient. They can try to hide or whatever. And say, oh no, I don't have bipolar. It's like, why'd they give you lithium? Everybody that has bipolar has been diagnosed. You can't get lithium at 7-Eleven. You get diagnosed with bipolar, you have a prescription for lithium. Is everybody good with that? Burn that in your head. That's like one of the most frequent ones. All right. This one. I don't know why they ask you that, but they do. Carbidopa levodopa. It is. So everybody that has Parkinson's takes carbidopa levodopa. It has 2 doses in it. It's like a 3 something / 150. It's half of 2 it's 2 medicines combined. All right, but everybody that has Parkinson's, diagnosed Parkinson's, takes this med, and what they do is they adjust those medicines. So like when you meet a Parkinson's patient, it's like, we've really been trying to play with his meds to get it dosed right and stuff like that to reduce the tremors and it's not all tremors. It's different. It's a movement disorder, but they're not all shaking. They have different variant forms of Parkinson's. But they all take carbidopa levodopa. The other question about Parkinson's, what causes Parkinson's? Look at the name. What do you think? Just off, I'm pointing at the last 4 letters of each word. It's a lack of dopamine in the brain, the chemical neurotransmitter dopamine. All right. So guess what? It's kind of in the name. They're giving you a supplemental dopamine to replace the dopamine you're losing. Does that make sense? If somebody's taking testosterone, what do you think they're short on? So it's exactly like testosterone treatment because they're playing with you and giving you higher, lower doses to try to get your symptoms resolved. Same thing with testosterone. They're trying to get you to the level, get you back to where you were and stuff like that. Does that make sense? Anytime you take synthetic something, and this is just good to know about the body, what do you think your body stops doing?
Producing it.
Right, whenever you take an excessive amount of melatonin, what natural melatonin.
Yes. When you supplement with something, your body will stop producing it. So if you supplement with testosterone, guess what? Your body stops. So another thing is, people take, there's another drug to add to it. Does anybody have any asthma or big time allergy problems?
My daughter does.
Has they ever put her on prednisone? All right. Prednisone, remember we talked about what does corticosteroids do to the body? They suppress what? Suppress your immune system to what? Open up your airway and make it easier to breathe, right?
Yeah.
So suppress your immune system, open up easier to breathe. So if you have breathing problems, guess what? Most likely you've probably been on prednisone before. Prednisone is the one where you do like this. You take, I'm going to take it to the nth extreme, but like you take 20 tablets for the first 5 days, and then they knock it down to 16, and then they take it down to 10. And it's like a 3-week deal, but they walk it down.
Yep.
Do you know what that process is called?
Yeah, you're weighing them down.
It's called a taper. So initially, I'm giving you all the corticosteroids here. All right? Now, what happens is, what does your body stop producing?
Yeah.
Corticosteroids in the adrenal gland. So, why do I taper you off? To allow your body to start producing again as I'm weaning you off. Just like if you take testosterone, I always relate it back to something I know. I take testosterone. You cannot abruptly stop testosterone. You'll bottom out. What happens is the guys that have to come off testosterone because it makes it harder to get pregnant, they decide they want to get pregnant, or wife wants to get pregnant, they have to wean them off so their body's natural testosterone will start taking over again.
They just came out with a new one that's kind of like, it's supposed to increase fertility rate.
Really?
It's like, dude.
They'll find some way to fix some problem, you know. Yeah, you get to buy it to them, and so that's all the good stuff.
Not regular.
All right, so, but I kind of want you to understand that about medications. Whenever you supplement, you have to understand your body's going to stop producing it. But this is synthetic or supplemental dopamine, chemical neurotransmitter dopamine that you can take in a pill form, and it's supposed to stimulate your production of dopamine in the brain. What's up?
I'm trying to get here.
I sucked in the brain.
You did?
Yeah.
You didn't see my sign?
No.
That sign especially for you.
What is it?
Somebody was looking for me. Putting out fires already.
Mm.
How many of y'all ever been shot at? Or had guns go off around you while you're on call?
Yeah.
It's part of it. Oh. You want this?
Sure.
Oh. One of the guys in the 60s worked at CPR at 3 o'clock this morning. Shots fired. But yeah. Nobody got shot. They just shot up in the air and made a lot of noise and said that if they don't make it, I'm going to kill you.
Yeah.
So when he went inside, they scooped the patient up, hauled out to Federal Walk Stanchi, and the guy showed up there with a gun. Went into full lockdown mode.
Holy cow.
You remember all the fun you used to have when you was director and you had to notify all the chain of command and shit?
Yeah.
Here, most everybody, fuck you.
Closest I ever
He's the
came,
reason I got this stupid ass job.
hey, the closest I ever came was I heard God talk back.
You heard God talk back? You was the patient.
You know, we were just fought a fire, lightning
Yeah.
strike fire. It was a 2-room upstairs, great fire, made a great stop.
Mm-hmm.
And we get there and it was like, we were quick, it was like the work was done so quick, we were like, holy cow.
Yeah.
And so we were like, all right, so we started doing overall, and it was like, everything's going good. And I just leave apart, I said, you know what? I said, I could really go for another one of those. No lie, 2 seconds later, lightning strike.
Really?
The house behind, like the house across the street, there was a house behind it.
Yeah.
On the next street
Set
over.
it on fire?
Yeah, and we're like shaking, going like that. And then we're like, no way. And then they started reporting out structure fire, and we had shit blocked everywhere. And it's like whenever you have all your shit out, and like, oh, by the way, there's another call, and you're like just trying to screw them to do that.
Yeah.
Yeah. But I have not had the guns fired.
It's
I've had guns on scene.
guns on scene, shot at, got shot once. It's fun. It's part of it.
Yeah.
I still got the job shirt when I got shot. Got covered by a shotgun. You remember
Shot
what
by
it's
me.
like? This whole side, it looks like I got shot.
Yeah.
Yeah.
This shot with a BB gun. That's about it.
It feels like a bunch of BB guns at one time. I would say like somebody throwing a handful of rock salt and bumblebees at you. And then for some reason, when it hits you, your underwear turns brown for some reason. Probably from here to the other door.
Okay. I've been peppered, but to whether you can still feel the heat of the BBs, but not the.
I don't care how cool you are. When you get shot, you can't just say, paramedics.
Yeah.
Fuck! I'm hit! I'm coming, Elizabeth!
I'm down.
Yeah. Oh. Gracias. Anybody else?
I'm gonna grab my after lunch.
Okay, grab yours lunch.
Go.
I'm gonna go back and take care of the shit that you used to take care
I'm gonna enjoy doing this. Go ahead. Yeah. You probably done some of these.
I got a few not too long ago.
You probably done
of.
some.
I could use some.
What's up, dude?
Any of those that won't show up on drugs.
No, you left.
So, carbidopa, levodopa. Like to go with me in the brain for Parkinson's, and they take supplemental dosing. All right. This one. What is this?
For cholesterol.
Yes.
Low.
So, common grouping, just the same way as LOLs.
Seven.
Atorvastatin, simvastatin. There's one that starts with an N, I can't remember. But the Crestor and the other stuff that you're used to is just, all right, that's like Viagra. What is that called? It's like it's not the generic name, it's the brand name. So your brand name is, just like, what's the brand name that you're used to for acetaminophen? Even so much that we give oral acetaminophen, and we give IV acetaminophen. We call it Opharmia, but like, even the guys, the common sense, they just label it, even on the deals, they're like, this is oral Tylenol, this is IV Tylenol. I go, it's not Tylenol. And they go, whatever. And it's acetaminophen, same thing. So, always remember the brand name is when you think of the brand name, think of commercials.
Mhm.
You know what I mean? the generic name is what it is. Is that right?
Mhm.
Generic name? I'm making sure, because I might mess that up too. But if it is a statin, like if they give you a drug and say, what's it for? And you don't know around it, look at the word and see if there's something that pops out. But it always ends in statin. Atorvastatin, simvastatin, there's something in there. All right? All right, now, we're going to go through your blood pressure medicines.
Mhm.
Common home blood pressure medications. All right? I want you to think about this. Remember, I told you I'm going to keep referencing this. Heart rate times stroke volume equals cardiac output, right?
Mhm.
Cardiac output times systemic vascular resistance, your ability to squeeze, gives you your systolic blood pressure, right? All your medications, home medications for this, work on this deal. So, labetalol. I think everybody knows labetalol is a beta blocker, right?
Mhm.
So, what does it work on? Heart rate. Heart rate. Keep the heart rate down. Does it eventually work towards the blood pressure?
Yes.
All right. Now, these two are similar medications. Lisinopril. What is the lisinopril?
It's an ACE inhibitor
ACE inhibitor. So where does it work in the rest?
in the lungs.
All right. It works in the lungs,
Stops
and it
it.
blocks that whole angiotensin process.
Mhm.
All right. What are the two end results?
Volume and pressure.
Say again.
Volume and pressure.
Volume and pressure. Where does that fit on there? SVR.
Yeah.
There's your constriction, right? And then what else? Maybe stroke volume or cardiac output. But for sure it works on this. Morning. This systemic vascular resistance. It's always, your ACE inhibitors are always going to be pearls. Alright? You know what losartan is. This is an angiotensin, renin, 2 words, and then the third word is blocker. The nickname that you're used to hearing, or you'll probably hear in the field, is they are ARBs. Alright? All this is, if you have a bad reaction to an ACE inhibitor, then they just give you an ARB. And it's, so ACE inhibitors work here, ARBs work there. It does the same thing. Again, SVR, systemic vascular resistance. It's losartan. Losartan is probably the most common one, but they all end in tan. Alright? Angiotensin renin blockers, your ARBs. ARB apostrophe S. How you're going to remember this is Arabians or tan. Just telling you, it's a good way to remember. Arabians or tan. These are 3 common home blood pressure medications that you will be assigned. If you are an Anglo-Saxon, white male, this is what they'll give you first time for new onset high blood pressure. 5 to 10 milligrams. Alright? Now, lisinopril is like the go-to. They have said that doctors have been accused of being racist for not assigning African Americans lisinopril for new onset blood pressure. Do you know why they don't give them lisinopril?
They have a lot of allergic reactions to it.
Mhm.
Yes. They are more prone to the allergic reaction. You can take lisinopril your whole life, but the bad part about this allergic reaction is it's very dangerous. You can have a minor side effect to an ACE inhibitor is a dry cough. You get a dry cough, they'll just give you losartan. Allergic reaction is, do you know what the bad allergic reaction is to lisinopril? It's angioedema. It's a common deal. So if you get the angioedema, what do you think happens to your airway? Closes off. They are more prone to the allergic reaction, the severe allergic reaction of, what do you call it? Angioedema than anybody else. But if you get the dry cough, they'll just give you losartan. I think both of them can produce the same. I don't know I know the Center Pro can't prescribe, I don't know about Losartan. But they will not prescribe African American, unless they know they don't have, I don't know, they can do tests on them, make sure they don't have the allergic reaction. All right, here's the other one. You can probably figure it out by the top one, because that's what you're most used to. But what kind of drug is it? It is. Hang with the broad brush. Shotgun, give me down to a rifle. You ready? Calcium channel blocker. That's what it is. Your calcium channel blocker does two things. These work on heart rate and lower your heart rate, but they also give you a little vasodilation. All right? So, calcium channel blockers are going to be Zim, how you going to remember it? Zimilpine, or Pine. Amlodipine, nifedipine, Rapamil, there's another mill, I just can't remember it. And Cardizem. We're used to Cardizem or Deltazem. Deltazem and Cardizem, same drug. Alright, Rapamil and Amlodipine, the other one being nifedipine. So if you see these medications in this, these four groupings, and they say, patient takes this, and they don't say, what is it? They say, what do they have? What's your answer going to be? Because I just told you these are home medicines for what?
Blood pressure.
Blood pressure. So if they have labetalol, lisinopril, losartan, Cardizem, Rapamil, all that, you say they have, you're looking for hypertension. If they take this, not high cholesterol, what's the medical terminology for high cholesterol? Hyperlipidemia. Lipid, fat base. So, high cholesterol. Parkinson's, bipolar. I may have misspelled the next one. Do you know what it is?
You did. It's COOPIDO.
Oh, that's it.
GREN. I Googled it.
EN?
Yes, sir.
Not EO?
Or EL. Yes, sir. But
It's Plavix. Is Plavix a blood thinner?
Yes.
No. Plavix is not a blood thinner. If you have a patient, you run on a patient that is taking clopidogrel, or AKA Plavix, most likely they are a previous stroke patient, recent stroke, or they've had a cath or something, some kind of procedure done on their heart. Don't think of it as a blood thinner, think of it as super aspirin. Works similar to aspirin.
You just a platelet aggregator?
Roughly, yes.
Okay.
But everybody always puts in the blood thinner category. Sometimes people put aspirin in the blood thinner category. It is not. Works with platelets. All right. So clopidogrel, 75 milligrams is the normal dose. You need to know that's Plavix, because they might ask you another name for it. So this is Plavix. All right. What do you think these are? These are your most common blood thinners. So warfarin and Coumadin are the same drug, made from rat poison. Did you know that? Yes, made from rat poison. Newer generation of drugs. You've seen these? Xarelto,
Mm-hmm.
Eliquis. Eliquis is the new hot and heavy one. So if your patient has warfarin, Coumadin, Xarelto, or Eliquis in their history, what do they probably have? Something to do with the heart, maybe a valve replacement, maybe some kind of bypass, like if they have like a big cardiac procedure, previous stroke. If you get a valve replacement and you get a artificial valve, you will be on blood thinners the rest of your life. If you do the pig valve, which only has like a less lifespan, less than lifespan, If you do the pig valve, then it actually, you don't have to be on, they might put you on Plavix for a little while and then you're good. What are the dangers of being on blood thinners? You already know one of them, we talked about it earlier. nursing homes. Falls. If you have a fall or a head strike with a blood thinner, you need to do what? Take them to the hospital. What they're going to be looking for is a subdural bleed. That's probably the most common, that worst outcome for those patients. All right? What do these people have to monitor every day? There's a certain test they have to do. It's almost like a D-stick test now. It's a big machine, but you just take a capillary blood test, and you have to do it daily. Have you ever heard of INR? You ever say, hey, what's their INR? The INR measures their ability to clot, it's the levels of blood thinner in their blood, basically. So if your INR is real high, that's dangerous for them. What they want is an INR that's like 2 to 3. All right? So if their INR is 2 to 3, then they're right where they need to be. But if their INR is 27, then a good strike, they could bleed real easy. All right? It's just something you might run into, but it's an INR test. Again, they need to be low. Things that mess it up are stuff like people that take blood thinners, they're not supposed to eat. People that take blood thinners are not supposed to take, well, let me ask you about this. Did your dad say that he doesn't need to eat green leafy vegetables? All right. So your diet, if you have a diet if you're a person that eats a lot of roughage, if you are consistently eating roughage, then your INR will stabilize and come down. But if you're a person that all of a sudden like, hey, I'm just gonna start, like my meal tonight is like salad and this and kale and all this other stuff. Like you eat a lot in one day, it's gonna shoot your INR up for that day. That doesn't mean it can't come back down the next day. But for that day, you're in the danger zone. But if you eat it consistently, then your INR stabilizes. Get used to it, you know what I mean? But people that take blood thinners cannot, they try to stay away from doing a lot of green leafy vegetables because it can take their INR on a roller coaster. Does your dad take
healthy foods?
Does he have this big D-stick looking thing that measures INR every day? Like, does the thumb prick? Usually they do for, because usually you have to go to get a test done.
He used to do when he was on, I think he was on warfarin, he had to go and do he called it the Houlihan Clinic.
Yeah. Usually you have to go in for it, but now they actually have home deals you can measure it.
Yeah.
But I don't know how good the new drugs are if you have to go in and do that as much.
I mean, he doesn't do that now.
My dad was, I can't remember which one of these he was on, but he had to do that, and I had to show him how to use his little machine or whatever. All right, but these are all blood thinners. These are common brand names. Those are that's old school. All right, DIG. All right, the important things to know about DIG. If they say your patient has Digitech, Digoxin, there's another DIG word, but it all starts with DIG. If they have that, most likely they have CHF. The good part about DIG is it keeps your heart rate low, better than a beta blocker. The down part is it has a limited therapeutic window. So your limited therapeutic window means it's easy to overdose, it's easy to underdose. And there's a limited window where it can work. Now, they have it, usually they have CHF. That's a common medication for CHF. It's rarely used because it has good effects to some people it doesn't. If you overdose on Digitech or Digoxin, and they still use this, the sign they will see yellow halos or green halos around lights. If they see that, then they have Dig overdose. Okay? But if they have the medication in their history and they're seeing green halos and stuff like that, it's a Dig overdose. But it keeps their heart rate, and people with CHF, they absolutely want to keep their heart rate about 60. They don't want to get excited.
My dad was like between like 40 to
especially with DIDs, because DIDs work so good. And then prednisone, that's a corticosteroid. What are the other ones we talked about? Solumedrol is another corticosteroid. Solucortef. Anything with, somebody asked about one, sulfazone. Dexamethasone is another corticosteroid. It's a supplemental corticosteroid. All right. Trying to think of any other kind of just a little bit. They're little one-off questions of what do they have or what does this do? And the drugs we're going to go over today for ACLS, you'll have to know the yes, you got to know the dosages. ACLS and PALS is the only thing they're asking you on dosages for. All right. Just a real quick one on paralytics. If they ask you about paralytics, they're going to ask you, what do they do? Sucks. Sucks has a short-acting window, right? Do you know if it's a non-depolarizing or depolarizing?
Depolarizing.
Depolarizing. How do you know that?
It's the only one that depolarizing.
Okay, now that's a good way to remember it too. So whenever you look at you don't have to draw this up there, but you remember the whole sodium potassium pump, Axon, Dendrite? It looks kind of like that or whatever. So when the message crosses the deal, you get a it changes the polarity of the cells and you get depolarization, right? Here's the deal with sucks. That's why it's called a depolarizing. Every one of your cells in the body, it fires all at once. It fires and then it stops. It never reloads the gun. It's like boom, and never pulls back and loads another shell. It depolarizes and then boom. So what happens is you get fasciculations all over your body. So how you know sucks is starting to work is they will start doing this number. Have you ever given sucks or seen them give sucks and it does this? Yeah, that's the depolarization happening. That's how you know it's a depolarizing paralytic. Every other one is a non-depolarizing. So a non-depolarizing is like putting the safety on and trying to fire the gun. None of them fire throughout the body. It just stops it right there. It stops it right here. That is a non-depolarizing paralytic. So you never get the fasciculations or any of the other stuff. Usually the non-depolarizing ones are the ones that last a little bit longer. If you're like Rock and Beck, they last, what, 30 minutes? Something like that.
Roughly, yeah.
Now, you use Rock and Beck, just because they're paralyzed, does that mean they can't perceive pain? Remember, what I talked about with sedation. Have your sedation ready. What are the signs that somebody's coming out of sedation? Curare cleft. It's a little notch at the top of the interstitial. Tears. And
Increase in heart rate.
increase in heart rate. Good. All right. How many of y'all looked over the 225 guidelines? Be honest with me.
I couldn't find it.
You don't have Google.
I guess not.
I got confused.
No, you just forgot. It's okay. Just say you forgot. Just say you forgot. Okay. You reviewed them, right?
What?
You
Yeah.
reviewed them?
I went over a little bit yesterday on it.
All right. So, what I'm going to do is I'm going to pull them.
I'll print them off if you want them.
You print them off?
Yeah.
Yes, please. Sweet. All right, thanks for listening. Adult cardiac arrest. Tachycardia. Tachycardia. All right. So, we'll start with, I'll start with the one that's probably going to trick you the most. Adult brain, we'll start with adult brain. And then we'll do pediatric brain.
Something I was taught for the bradycardia is Mr. Brady always plays dominoes at the afternoon his dopamine.
How about all trained dogs eat? Atropine, TCP, dopamine heavy. It's mine, might be it. It's an old school one. Alright, so how it starts off, this is, you're gonna get this little box for everything. This little box will be for your tachycardias and bradycardias for adults. Alright, so it'll be a little box. It'll have 5 things. Hypotension, altered mental status. What else is it? Acute altered mental status. Signs of shock. Ischemic chest discomfort. And then acute heart failure. Alright. Let's say hypotension, it's going to be BP less than 90. Acute altered mental status is pretty self-explanatory. Everybody good? Or explanatory. Everybody good with that? Signs and symptoms of shock. But honestly, this is what it's going to be. Ischemic chest discomfort. Why do you have ischemic chest discomfort if your heart rate's 30? It's a lack of, it's a inequality in the mind. You got more bleeding. Yeah, but you're not having your heart rate. You're not getting. I'm trying to say myocardial oxygen demand. It's not meeting the myocardial oxygen demand. Does that make sense? And then acute heart failure. Rattles and crackles. Alright, so acute heart failure, you would, like, remember I told you there's like cardiogenic and non-cardiogenic pulmonary edema? This would be one of your cardiogenic pulmonary edema. You used to always be in CHF. You could get your lungs starting to fill up with fluid because your heart rate is so fast. Alright? So did I do the Brady tachy deal with this? Like how the cardiac output's reduced by explaining the blood pressure and stuff like that?
Good job.
And do that in the previous notes? Alright, so we'll do it right here. Alright, so just going off this, alright? Have you ever heard this phrase? Around here at the barrel. Sorry, it's an equal. 70 times 70 equals 4,900. It's like a big deal that Billy Whitson, one of our previous instructors, used to say. This is a normal heart rate. This is a normal stroke volume, so that should be a normal cardiac output. he used to go around saying that, and it sparked an idea in my head to help explain this. I go, well, essentially, I could say, hey, that's 120 over 80. That's a normal blood pressure, right? All right. Now, if you look at and we know what the deal is for BP, right? The secondary equation, right? Now, let's take a Brady example. All right. So let's say your heart rate is 30. Heart rate is 30. Now, does their stroke volume, just because their heart rate is slowed down, does that mean they get more stroke volume? Does it expand anymore? No, it stays the same. So you get stroke volume of 70. That equals 2100. All right. That is a greater than 50% reduction in cardiac output. So if that's reduced by more than 50%, what do you expect the blood pressure to happen? You expect You expect 70 over 50, right?
Yeah.
Makes sense. You may get $140 over 90. Why? Their ability to maintain a good squeeze. My dad was in a third-degree heart block. He called me down and he said, "Hey, did I tell this story to y'all? I did this the night before I did y'all, so sometimes they blend with some students at Collin." All right. He called me down and he says, "Hey, there's something wrong with my blood pressure machine." I was like, "Okay, what is it?" I live 2 houses down. And he goes, "It's saying my heart rate's 28." I was like, "Okay." And I was like, I go down there, check it out, and he said, "What's wrong with it?" I said, and I took his pulse and I go, "Your heart rate's 28. Your heart rate is 30. He goes, "Well, what does that mean?" I said, "Okay." I was like, "Have a seat." I go, "I'm going to explain some stuff to you." And I said, "I'm going to explain what the next couple of days look like." And I said, "And we're going to make some choices." And he goes, "Okay." And my dad is non-medical. All right. And I couldn't have done this better if I was like Nostradamus picking out the future. All right. So I figured it was a block because sinus Brady doesn't happen at 30. If you get a sinus Brady, maybe in the 40s, but not in the 20s. All right. So his blood pressure was 140 over 90. And I said, "You probably have a heart block." I said, and we live right over there across from Tuscan Slice. It's where I grew up, and Chapman Edition. So I said, "Look, we can go to Baylor Waxahachie." They're going to freak out a little bit. And I go, and they're going to send you up to Baylor Dallas because they can't take care of it there. They're going to send you up to Baylor Dallas. And I said, they're going to run a lot of tests. Most likely, you'll probably end up with a pacemaker. And he goes, "Okay." He goes, "What's another option?" I said, "I can take you straight to Baylor Dallas because your blood pressure's good. I can take you straight to Baylor Dallas." I said, "It'll be a one-stop shop. They'll just wheel you across the street to the cardiac place. And I go, and we'll be good." And he goes, "What's the other option?" I said, "We can go to Methodist Mansfield and do the same thing, one-stop shop, because they can handle it, because I know what the hospitals can and can't do." He goes, and of course, he takes the lesser option because he thinks this will just be something I can take a pill for, just like he takes 20 other pills for. And I go, "Okay, cool. He's earned that right to make that decision. I'm fine with it. It's my dad." And I go, "Let's take you to Baylor Waxahachie." I walk in. They said, "What's the chief complaint?" I go, he's probably got a heart block." And they're like, "You're full of shit." I was like, "Okay." And I was like, "Wheel him in there and check him out." Wheel him in there and check him out. She comes out and says, "Oh my God, this guy's got 3rd-degree heart block." I go, "There." I was like, "Have at it." And so they take him back. Take him back. I know what's going to happen. They're gonna run some tests and blah blah blah. And they're like, "Hey, we can't treat this here." And they're gonna take him to Dallas. And they offer us. They said, "We can fly him or we can ride him." And I was like, "Here, let me ask him." And I go, "Hey, you want to get in a helicopter or so you want to go by ambulance?" "I ain't getting no fucking helicopter." I was like, "Okay, all right, no big deal." So they take him up to Dallas. He maintains a 140 over 90. that night. They wake them up in the morning. They're always gonna, before they go straight to the fixing the electrical, because this is an electrical problem, right? 3rd-degree heart block, but it could be what? A plumbing problem.
Yep.
It could be a lack of blood flow to your electrical system. So it's not a real it's called like a pseudo 3rd-degree block. If he has a blockage and they fix it and he goes back to a normal sinus rhythm, all done. We don't have to get a pacemaker. So they always check out the plumbing first before they do the electrical. He goes through the plumbing, no blockage, no big deal. Okay? They go in there, they put the pacemaker in, he maintained that blood pressure the whole way. Now, while we were at Baylor Waxahachie, we had a nurse freak out, and they go, and he did a good thing, and he walks in there and he goes, "What are we doing?" And like, everybody's just sitting around like it's a normal Sunday, no big deal. And he said, "What are we doing?" And he's like, this is a bradycardia, and starts slapping pads on him. Why did they slap pads on him?
Because it's great.
Because at any moment, he could lose that squeeze, and then this is where he goes. And what do you think they're going to start doing? They're going to start treating him. So in bradycardia, if you meet any one of those criteria, that makes you symptomatic. Your whole non-symptomatic, symptomatic, it's if you meet one of those criteria. So they were constantly checking breath sounds, checking his mental status, making sure he wasn't having chest discomfort, and they're watching him for any kind of acute heart failure, altered mental status, or low blood pressure. The moment you hit one of those criteria, you become treatable. So that's your symptomatic. I've had 3rd-degree heart blocks in the field, and they wouldn't let me touch them because they're just sitting there like no big deal. All right. So again, you may expect this, but you get this. It doesn't mean don't be prepared for this. How do you get prepared? Do you know ACLS recommends that you put pads on any tachycardia, any bradycardia, or any acute MI? Because you need to be prepared for, I need to pace, I need to cardiovert, or I need to defibrillate. So it's a good practice to go ahead and put pads on patients with MIs, Brady's, or tachys. That's the recommendation. Because what do they say the big deal is for it's early defib to get somebody out. And remember, that first 4 to 6 minutes, that's where probably they're in defib. And the best treatment for defib is early defibrillation in an adult. So if they ask you about that on National Registry, the chain of survival, it's going to be, for adults, it's going to be early defib. Early notification and early defib. All right, that's why they try to put AEDs everywhere. Because if you can get them, there it is. If you can get them there, get them defibrillate quick, you got a better shot at getting them out. All right, so it says, hey, if they have any one of these criteria, then they're treatable. All right, if no, identify and treat underlying causes, provide oxygen, support ABCs, do a 12 lead and observe. You're not doing shit, you're just monitoring. In real life, I want you to put pads on. All right, on this, it says maintain patent airway, assist breathing at positive pressure as needed. So the thing you gotta watch out for, what if they're like this? Let's say they're low blood pressure, hypotensive, and it says respiratory rate of 6. What do you need to do? You need to ventilate. So you gotta watch out for these little things. You gotta ventilate. All right? Attach cardiorespiratory monitor pulse. All right? If the bradycardia persists so you've done all your treatment, let's say you start bagging them, and their heart rate and their blood pressure comes up. What do?
Monitor.
Monitor. And keep bagging them. Yeah. All right? So if that fixes it, you're good. All right? But if it persists after that, here's your treatment choices. And this is where y'all get screwed up. Here's your first treatment. Now, what your instructors have taught you, and they're not wrong. Can everybody see that from back? I'm sorry, I used pink. Atropine 1 milligram. So, what your instructors have taught you is if there's a high degree heart block, you can't fix that with atropine. Have they taught you that?
Yeah.
Then they have done their job, because you can't. You're not gonna fix a third-degree heart block or a second-degree heart block with atropine. What does atropine do?
Increases the heart rate.
No, it doesn't increase the heart rate. Epinephrine increases the heart rate.
It's something with the parasympathetic system.
So you remember when we talked about ICP? Why are the signs of ICP, why do they get bradycardia?
Push on the vagus nerve.
It's pushing on the vagus nerve, right?
Yeah.
So you're getting vagal stimulation.
Yeah.
How do we lower SVT? Give them vagal maneuvers, right? Trying like that. If vagal activation is your issue causing the bradycardia, then atropine will reverse it. Does that make sense?
Yeah.
So if you have a sinus brady of 50 or 40 and it's due to vagal stimulation, you give atropine and it works, then the vagal stimulation was your problem. Does that make sense?
Mhm.
It doesn't increase heart rate, it blocks the thing that's lowering your heart rate.
Like, what's the organophosphate?
Yeah. No, exactly. It treats the sinus symptoms, but it will, if vagal stimulation is the cause of your bradycardia, it just blocks it. It gets out of the way. Just like if people are like, it's like Narcan. Narcan blocks your opiate receptors, right? And then it makes them come back and start breathing and all the other good stuff again. So atropine works on one thing. It doesn't increase heart rate. It blocks the thing that's keeping your heart rate down. Does that make sense? Okay. Now, your second option is going to be a pick 3. And this is straight from ACLS. So if you have a bradycardia, if you have a third-degree heart block, and it gets to a point, and they're meeting one of these criteria, and you know you're going to treat it, what's your first option?
Face them.
No. No. I just put it up there.
Oh.
This is where y'all get tricked at. Because you know it won't work, but ACLS writes it like this. It says, first option, atropine. It says atropine. If atropine is ineffective, then we go to the other 3. So the first answer you're looking for is atropine 1 milligram. You have to trick yourself out of it.
Okay.
All right? Because this is what the National Registry goes by on the test. In real life, yeah, stick away from atropine. Go ahead and pace it. That's the best option in real life. This is on this test. On this test, atropine is your first option, no matter whatever the bradycardic rhythm is. Heart block, third-degree heart block, first-degree heart block, sinus brady, I don't give a shit. Atropine's your first option for treatment. 1 milligram. Make sure it's the right dose. All right? Now, your second option is a pick 3. TCP. Sorry, I'll do this. So everybody can see it. TCP, transcutaneous pacing. All right, tell me this. What's your rate?
80 to 20.
Huh?
80 to 20.
60 to 80. It won't say it on the deal, but it's 60 to 80. All right? So if it says set the pacer at 75, does that work? It says set the pacer at 60, does that work?
Yeah.
It says set it at 80, does that work? Yes. All right? So TCP 60 to 80. Or dopamine 5 to 20 mics per kilogram per minute. Or epi infusion, which is just an epi drip. This is a dopamine drip. Epi infusion, 2 to 10 mics per minute, not weight-based. So if it says you have a third-degree heart block and you've already given atropine 1 milligram, and it didn't work, shocker. Didn't work. And it says, what's your next round of treatment? only one of these is going to be a A, B, C, or D. All you're looking for is one of these three. It's not in order. How you can remember that is all train dogs eat. Just an old school way of remembering the drugs, the treatments. All right? Ten to 10. It says possible causes. Could be myocardial ischemia or infarction. Like I said, it could be a plumbing problem. All right? It could be drugs or overdose, toxicology. What could be these? Just went over some drugs that lower heart rate.
Well,
It says could be a drug or toxicology overdose. Digoxin, because what does it do? And it has a limited therapeutic window. It's easy to overdose on. So outside of seeing the green halos, what do you think your heart rate would be? Really, really low. All right? Beta blockers. Now, do you have anything to reverse the dig overdose? No. You just keep treating down this. Beta blocker overdose. Do you have anything to reverse the beta blocker overdose?
Yeah.
What is it? Say it. It is glucagon.
Yeah.
All right. Now you're used to glucagon being given for what? Low blood sugar, and it's an IM shot.
Yeah.
For this, it's IV, and it's 2 to 5 milligrams. So it's 2 to 5. Glucagon's come in 1 milligram little packets. It's 2 to 5 of those. And what happens is, it's the same way as an opioid overdose. It blocks those receptor sites. So like whenever you get like, if you have a, let's say you have a, let's think of a cell as a house. Shitty house. And you got your 2-car garage. All right? Your garage, those are your receptor sites. What will happen is, it will pull the beta blockers out, pull those cars out, and it will close the door, close the garage door so nobody can go park in there. Or it will park the glucagon in there so nobody else can get in there. Same way, that's the same thing that happens with Narcan and opiates and stuff like that. It pulls the cars out of the garage, either parks it in place or shuts the garage door, so that it doesn't have that same effect on the cell. So, beta blockers, you give glucagon. That's a natural register test question. Calcium channel blockers, they lower heart rate. What could you give? 2 things. What would be the most obvious choice? Calcium channel blockers. What do you think, just off the name, what do you think would be the... You have calcium. The other thing is, you could also give glucagon to that. If it's a Zenmilpine or it's an LOL, and it's an overdose and they're bradycardic, you still go through your treatment, but now we throw in extra. Hey, let's give them some glucagon. If you don't have glucagon for calcium channel blocker, give them calcium. Try to reverse that.
Is it the same dosage?
Huh?
Is it the same dosage?
Calcium will be 10 milligrams per kilogram. So usually calcium chloride comes in a 1 gram vial. So it comes in a 1,000 milligrams. So if you think of a 100 kilogram patient times 10, you give them a whole vial. And then calcium gluconate, I think, comes in 3 milligrams. I may be wrong. I'm trying to remember off the top of my head. But usually it's calcium chloride, 10 milligrams per kilogram. But you need to have these things memorized, these 5 things, because it plays into the tachycardia algorithm too. Now, have y'all gotten a dopamine question, calculation?
No, sir.
Have you gotten an epi calculation? All right.
I think there was only one,
I can make it a lot easier for you.
there's for a weight-based dosage, and it gave you
Are you talking
everything.
about the one like the drip rate?
Yeah.
Yeah, I've gotten one.
All right. I'm gonna make it a lot easier for you. Usually I do this at the end, but we'll just go ahead and do it right now.
What is it, TD over the time?
Yeah.
No, it's clock method. Clock method works for anything that you're gonna do in the maintenance strip. And if you want antibiotic, I can make it easy.
Is this for your
Did you get one? Have you got it before? Yeah. All right. So everybody got this down, right? So there's 4, let's say 5 possible drips you can be asked. Dopamine, epi, lidocaine, levophed, and the other one's amiodarone.
So dopamine, epi,
Lidocaine, levophed, and amiodarone. So I'm gonna keep this up here, but we're gonna do a little sidetrack. We'll do a little math before we take a break. Think you can handle it? All right. So, what is a maintenance strip? Like, when you think of maintenance strip, what do you think about?
It's a constant.
Yes, titrate to effect. So like if somebody is on, have you all been in the hospital and saw like somebody get put down for RSI and they put them on, what's the milky stuff called? The stuff that Michael Jackson overdosed on? Propofol. You see them put them on a propofol drip or something like that to keep them sedated? Alright, so if they start coming out of sedation, what do? Give a little bump in the propofol. Sedate them a little bit more. Just like you would give a little more medication, right? But we're trying to maintain them in this window. We got something that's working that's effective, and we're trying to keep them in that window. Does that make sense? So, what we're going to do is, we're going to learn something called the clock method. The clock method works for maintenance strips. I'm going to show you how to do it, and then I'm going to give you the easy answer for your national register so you don't have to take 5 minutes. So I'm going to show you how easy it is. Alright, so, clock method. Anytime you do a maintenance strip, you have to do a 60 drop set. Alright? Do you know what like when they say a 15 drop or a 10 drop or a 60 drop set, what does that number mean? How many drops to get 1 milliliter? So if you have a 60 drop set, 60 drops fall, that's 1 milliliter. 60 drops looks like the little needle at the deal, whereas the 15 drop set, those are for your big ones, like, trying to get a lot of fluid. 10 to 15, 10 drops fall, it gets you 1 milliliter, okay? So, what we're going to do is we're going to make ourselves a little clock. And a clock has what? 60 seconds in it, right? 60 minutes, 60 seconds, depending on which hand you're watching. 15, 45. This is why we call it the clock method. Your first, now, the difference in dopamine is, dopamine's your only weight-based calculation. So, if dopamine, your first deal is, you need to convert any weight-based doses.
That's you said dope method?
This first rule only applies to dopamine. You need to convert any weight-based doses to kilograms. So like, let's say you have, and we'll use we'll do dopamine as our first one. This is your order. Alright, they want you to give 10 mics per kilogram per minute to a, let's say, 250-pound patient. And they want to know drops per minute. Alright? So, to convert any weight-based deals, we need to convert 250 pounds to what?
Gunner.
So, you have everybody knows you get a calculator on this test. It's the computer calculator, they'll show you where it's at. So go and use your phones, 250 divided by 2.2. Alright? So, 113 kilograms times 10 micrograms equals what? 1130 micrograms per minute. All right, we solved the first problem. 2 is, oh, and by the way, your supply, it's given to you like this. Your supply for dopamine is 800 milligrams and 500 milliliters. That's how it comes supplied. Your second problem to solve is get the supply equal to the dose in units. So how did it come supplied?
800
Milligrams. How is it dosed?
micrograms.
So we need to convert milligrams to micrograms. So how we do that
60
is 800 milligrams. We take that 800 and we go 1, 2, 3. And we get 800,000 micrograms and 500 milliliters. With me so far on that? We're just making it all, we're evening everything out. Your third problem to solve is to figure out how much medicine per milliliter. So what we do is we take 800,000 divided by 500, the solution, right? Cross out the 2 zeros that you don't need, so it ends up 8,000 divided by 5, and you end up with 1,600 micrograms per milliliter. Everybody with me so far? 4. Put the amount of medicine per milliliter at the top of your clock and fill out clock. So, we know 1,600 is per milliliter, right? I know 60 drops get you 1 milliliter. So we put 1,600 mics. Half of 1,600 is what?
800
Half of that is what?
400
Does everybody get what I'm doing here? Alright? Now, the last part, 5, is to solve your problem. What are we looking for? 1130. This is 1,200, right? Halfway to here is 1,000, right? And then 37.5. I need 1130, so it's probably halfway, a little more than halfway to here. So it's probably around 41 drops per minute, or sorry, 1130 is probably around 40. Let's see here, halfway to that is 41, so it's probably about 42 drops per minute.
Mm-hmm.
Does that make sense? I can make it even easier than that. You wanna know the easy part? Dopamine comes packaged like this every time. It's either 800, 500, 400, 250. Either way, the ratio is the same. So if you know dopamine is 1600, you get a dopamine question, make your clock, fill it out, dopamine 1600, you're solid. You can figure it out. They're not going to put the answers if the answer is 42, it's not going to say A is 43, B is 42, C is 41, and D is 40. You know what I mean? Here's how they do it when they answer it. So dopamine, you said we said the range earlier was 5 to 20, right? Dopamine gets dosed in 5, 10, 15, or 20. Does that make sense? So what do you think the answers are? They're going to be 5, 10, 15, and 20. As long as you know if you're doing the math right on your deal, it's a 10 microgram deal. It comes right. As long as you get this number, this is really the only math you need to do. So you got to convert that to kilograms and get the full dose. As long as you can get the dose, I got you there on the clock.
Mm-hmm.
That's all you have to do. You're going to be stressed to the max. And everybody freaks out over a dopamine question. Don't freak out. It's the same fucking packaging it has been for years. Does anybody carry dopamine on their ambulance? You do? Have you looked at it? It's probably 800 to 500. Yeah. It's a normal packaging for dopamine. The other one would be 400 and 250, which is the same ratio. All right. So, there's your dopamine. What did I say the next one's going to be? All right. Does anybody know how to make an epidrip? All right. So there's your dopamine. This is our epi. It's not weight-based. So let's say your epi order is they want you to give 6 micrograms per minute of epi to a patient. Don't care what his weight is, like that. Alright, so we don't need to do one. Alright, and your epi comes supplied. This is how you do an epi drip every time. 500 milligrams and no, 2 milligrams and 500 milliliters. 2 milligrams and 500 milliliters. So, get the supply equal to the dose in units. So, how do I turn milligrams into micrograms?
3.
2 milligrams. 2, move it over 3, it becomes 2,000 micrograms and 500 milliliters. Alright. Then, how much medicine per milliliter? What's 2,000 divided by 500? 4. So you can do 2,000 divided by 500, cross out the zeros, 5 divided by 20 equals 4 micrograms per milliliter. So put the 4 up there, 3, 2, 1. It says it wants you to give 6. Well, if I go around once, it's 60. I need 2 more. It's 90. It's 90 drops per minute. So I go around once, that's 60. Then I have to go another 2 to get, that's 4. I need to get 6, like that. It's going to be 90. 90 drops per minute. I just eliminate the first salt, the first answer. Alright. Let's do lidocaine. By the way, every comes packaged like this every time. So you know you start with 4 at the top. Your lidocaine. You're going to notice it's very similar to the supply. It just changes the units. It's 2 grams and 500 milliliters. The dose is 1 to 4 milligrams a minute. Let's say your doctor orders you to give 3 milligrams per minute. Alright? So, it's the same math. I need to change 2 grams into milligrams. The supply, give it equal to the dose. So, I'm going to do 2 grams, and then I'm going to take a 2, and I'll go 1, 2, 3, 2,000 milligrams, and 500 milliliters, and then I'm going to take 2,000 divided by 500 to figure out how much in each deal, and it's going to end up being 4 milligrams per milliliter. And so now it is milligrams instead of micrograms. They want you to give 3. 45. It's always going to be 30, 45, or 60. Because whenever you give lidocaine, and if it fixes them, you go up to the next unit for the drop, for the maintenance strip. So this is going to be 45. With me? All right. Next one. Levophen. Levophen comes supplied. Or 250?
Yeah.
Yeah. 4 milligrams and 250 milliliters. And they want you, I think the dose range is like 2 to 12, something like that. Let's say they want you to give 8 micrograms per minute. So, we got to convert 4 milligrams to micrograms. All right? So we got 4 milligrams. We're going to take it over, and we're going to take a 4. We're going to go 1, 2, 3, 4,000 micrograms and 250 milliliters. Now we got to figure out how much per ml. So we do 4,000 divided by 250. Cross out one of the zeros. 25 goes into 400, 16 times, 16 micrograms per ml. So here's 16 micrograms, 12 micrograms, 8 micrograms, 4 micrograms. They want me to give 8, that is 30 GTTS per minute. These 4 drugs always come packaged like that. Now, Levophen, or no, amiodarone, I don't know if they'll ask you amiodarone drug, but here's the deal with amiodarone. If you convert somebody with amiodarone, and you want to hang an amiodarone drug, it's 1 milligram per minute for the first 6 hours. So, if it comes packaged, honestly, if you ever have to do it, just make it even. Make it a 1-to-1. Because you can do that with your bag. If you have a 500 bag, put 500 amiodarone in there. and run it at what, 60 drops a second. Do it a 1-to-1. But usually the amiodarone will be the kind of the fluid over time deal, but I don't think they'll ask you amiodarone. It'll just be like, hey, you need to do an amiodarone drip if you convert them with amiodarone. So converting something like lidocaine is used the same way in tachycardias that amiodarone is. So if you convert somebody in VFib with lidocaine, to keep them from going back into VFib, you hang a lidocaine drip. Does that make sense? If you eliminate all their PVCs, like they were doing like over 10 PVCs a minute, and you you do a lidocaine live man dose, like a bolus, you do a bolus, and then you do a maintenance drip. You've all done this before. Does anybody in here not drink? Okay. Have you ever gone, hey, have you ever wanted to just maintain a buzz? So you do a couple power shots or something like that, get you feeling good, and then you just do like a beer every 30 minutes. What happens if you keep doing shots? You're going to overdose. If you stop drinking, you're going to lose your buzz. But your whole deal with the maintenance drip is to just maintain that buzz. What we're trying to do is maintain that level of medicine in the body to keep them from going back into VFib. With Levophed, what are we trying to maintain? What does Levophed do? Blood pressure. Mm-hmm. So we're trying to, in that therapeutic window, if we're trying to keep them above 90 or right at 90, we tailor our drip to keep them right at 90 because it's a pressor. Dopamine does two things. It can be used as a pressor, or usually in the 5 to 10 dose, it's used for bradycardia. So we're either trying to keep their heart rate up because it has beta-1 effects. It also has alpha-1 effects as a pressor, the higher dose you give. So if we're giving 15 to 20 for a pressor, then we're trying to keep the blood pressure up. Does that make sense? All right, now, I just showed you how to do the math. I can tell you this. They're all similar. Dopamine is 1,600. Levophed is 16. Mm-hmm. The others are 4. With me on that? Mm-hmm. DLEL. Whatever kind of acronym comes up for that. But this is like one of those deals, you know how they give you that, I don't know if you remember from EMT, and those of y'all take the paramedic know it, they give you a clear sheet and one of these pens. All right? Mm-hmm. If there's something I'm going to write down, just so I can reference it real quick, I can just go DLEL, and I go 1,600, 16, 4, and 4. As long as you know the lidocaine's 4. Epi and lidocaine are always 4. Levophed 16. So your two pressors start with 16. With me on that? So look at that right before you go in, before you put your stuff on the locker. This is part of your parking lot study stuff. Look at that before you go in the locker. Like that. You may get 1, maybe get 2 questions. But these are 2 questions that are high-level questions that you don't want to miss. And you don't want it to stress you out. I've already given you an answer. I told you how it's packaged. I told you how we get there. All you got to do is remember the DLEL, 1,600, 16, 4, and 4. Just like we did the matching question for the acidosis and the alkalosis, remember all that? We do that. There's a reason why I do that, because there's levels of questions. You get level 1 questions are like, hey, your patient takes lithium, what do they have? Bipolar. That's a level 1 question. Or, what is the other name? What is the medical terminology for high cholesterol? Hyperlipidemia. Those are level 1s. Level 3 are going to be like your scenario questions. Right? But your level 6 questions involve patho and higher levels of thinking. This is a higher level of thinking. Your acidosis, alkalosis are higher level of thinking. All I did is try to make those easy for you. If you make them easy, then you sit there and go, oh, that's just this. Then it's like, your question adapts to you and gives you a harder question. That's good. If you get those harder questions, it'll better for your score and your performance. With me on it? Mm-hmm. All right, let's take a break. And we'll do pediatric break. All right. Is green a good enough pediatric color? If you,
Pediatric cardiac arrest?
no, pediatric bradycardia. Pediatric acute altered mental status. Signs of shock. And hypotension. Now, we use 90 as our cutoff for giving fluids and trauma for hypovolemia, right, for blood loss. We use 90 for our cutoff for bradycardia for treating, right? This one, they're not going to give you, so you know what, you know how to figure out a normal pediatric systolic blood pressure.
Capillary.
Oh, age, 2 times age plus 7.
2 times age plus 70. So if you're looking for your 90 on a 6-year-old, what would you say think their 90 would be? What's 2 times 6? 12 plus 70 is 82. All right. So our 2 deals will be less than 2 times age plus 70, or the easier way to be that they'll give you is greater than 2 seconds cap refill. So if they give you a pediatric tachycardia, bradycardia, or a pediatric in shock, and they say cap refill is 4 seconds, that's just as good as saying less than 90 in an adult. That's what they're going to give you. If they give you a blood pressure, it's going to be less than 2 times your age plus 70. That'll let you know that they're hypotensive. Does that make sense? So those are the 3 things you're looking for whenever it comes to bradycardia, tachycardia, or just knowing that the kid is in shock.
What's their top one say up over there?
Acute altered mental status. 2 times age plus 70, less than 2 times age plus 70, and then, or greater than 2 seconds cap refill. That's how they'll let you know they're hypotensive. All right. So again, flow chart. It's going to say, do they meet one of those criteria? And it's going to say yes. And we're going to say yes. All right. Maintain, or if they're not, if they don't maintain one of those criteria, identify and treat underlying causes. So, let's say they overdosed on beta blockers. Grandma, that's like a number 1 scenario for kids, is they got into grandma's watching the kids, they got into grandma or grandpa's pills. They overdosed on the beta blockers or the calcium channel blockers. Then you give the reverse solution, right? But that's if they're not meeting one of these criteria. They're just bradycardic and they're playing around fine. All right? If they do meet one of these criteria, maintain patent airway and provide oxygen, assist breathing with positive pressure as necessary, and attach cardiorespiratory monitor pulse. What did they always told you about kids? Kids don't have cardiac problems. So what do you treat first? Respiratory. Take that box, is all they're saying. Do I need to ventilate them? Do I need to oxygenate them? If I can do that aggressively, quick. So, oh, by the way, I forgot to tell you, on the adult bradycardia, you know it's the heart rate less than what? No, 50. On the adult bradycardia. It's less than 50, it's not less than 60. No, it's heart rate less than 50, so put that on your, yes. Heart rate, it says it right there on your algorithm. Highlight it, I don't care, less than 50. Okay. So this one is going to be, so your pediatric Brady, heart rate less than 60. All right. If they meet one of those criteria, alright, they say, if meet just one criteria, then I'm just gonna label this as aggressive airway support. You get a minute to try aggressive airway. Can you reverse it with oxygenation or ventilation? That's all you need to think about. Attachment to the monitor, and it says bradycardia persist with cardiopulmonary compromise. Those are your signs of a cardiopulmonary compromise. Delta mental status, hypotension, all that. So if it progresses, start CPR. This doesn't apply to just neonates. This applies to pediatric. Do you know how high the level goes? At what point do we start considering these guys adults?
Like I know the weights.
Bingo. Say that out loud.
Secondary sex characteristics.
If they show signs of puberty. Yes. Breasts would be a good one for girls. Guys, it could be armpit hair. I mean, they're not gonna. I mean, you could have a picture of it. I bet you had it earlier.
Yeah.
My nephew is too. You're one of those guys that want to get a mustache going in 8th
Yes.
grade. I like it. But it's okay. Pubic hair, breasts, something secondary that shows that they're possibly signs of puberty. You treat them like adults. That's when they go to ACLS. All right. So if you had a 10-year-old, heart rate less than 60, and you did aggressive airway stuff, and their heart rate was still less than 60, and their acute altered mental status, you start CPR. It's not just newborn.
You said aggressive airway for 1 minute?
It may, well, I say you get a couple minutes just to try to reverse what's going on. Now, that could be a pediatric asthma attack. And if they're Brady, then they're probably late. You know what I mean? But if you can get treatment on board, or this could be a pediatric foreign body airway obstruction or choking. If you can get this stuff on board and get it reversed real quick, then you're good. You move over and we're good. But after this, they fall into this version of CPR. So, still heart rate less than 60. So aggressive airway. This is my labeling. Heart rate less than 60 still. We're going to start CPR. All right. How you're going to remember your CPR is this. Your drug regimen. Now, this is still Brady. This is not full cardiac arrest. We can still do some Brady things. This is not your cardiac arrest deal. All right? So, the all trained dogs eat. You do 3 of those things. So, we're still going to give them epi, just like it's cardiac arrest. What's the dose of epi? 0.01. All right? 0.01 milligrams per kilogram. All right? Atropine for increased vagal tone or primary AV block. So we're going to throw atropine on. What's the dose for that? 0.02. And then we're going to go to what? What's our T? They could go to pacing. It's not going to say on there, but it just said what it says on the third one, the next box. Identify and treat underlying causes. So if it's an overdose, we can do that. And then consider transthoracic, transvenous, or transvenous pacing. Transthoracic is TCP. All right. Now, when we do TCP, our normal rate is 60 to 80 for an adult. Do we change it for a kid? Yeah. What do you change it to?
You want to be over 100.
Huh?
You want to be over 100.
I don't see anything on there that says change it. You see anything? I always thought it was 100. But we're gonna pay, we could pace them. After we done epi and after we done atropine, you can pace them. Can you pace a kid, even down to a neonate? Can you do it with adult pads?
Yes.
Just do anterior, posterior. If you always remember, try to do your, and this is just good practice, anytime you place pads, always do anterior, posterior. Because if you end up putting them on a thumper, not a thumper, Lucas device, where does the Lucas sit right? So if you need to do a vector change or add a different set of pads, you have to stop the Lucas. So if you always do anterior, posterior, if you need to add a secondary set of pads for dual sequential or a vector change, you don't have to stop the Lucas device. It's just good practice. Okay? So, check pulse every 2 minutes. If you can't fix with pacing, epi or atropine or the aggressive airway, now we just go straight to the cardiac arrest algorithm. We just switch to that algorithm. Alright? But, if you can remember this, on your drug regimen, what place is this? What place is this? 0.01, 0.02. It tells you what your dose is. 0.01 and 0.02. How many of y'all have problems remembering pediatric dosages? Okay. Here's my little deal on it. All right, first of all, you got to know what a Braslo tape is. Does everybody know what Braslo tape is? Mm-hmm. The max on a Braslo tape is 36 kilograms. Mm-hmm. All right, so 36 kilograms equals what, 72? Damn near an 80-pound kid. All right, after that, you exceed the ability of a Braslo tape. Okay, now, there's certain rules. Pediatric dosages will never exceed the adult dosages, right? Mm-hmm. Here's how they're always going to give it to you. Let's say you had trouble remembering epi, and you're like, is it 0.1, is it 0.01, like that. So, what's your adult dose for epi in a cardiac arrest? 1 milligram. All right, 1 milligram. All right, and let's say you got a kid, and they give you, and remember, always convert the kid to what? Kilograms. All right, so let's say you have a we'll just go with 22-pound kid. So convert that to kilograms. It's a 10-kilogram kid, right? And let's say it says, hey, what's the dose for this kid for bradycardia for epi? You know 1 milligram is the adult dose. Let's say it's cardiac arrest. And you know the adult is 1 milligram. And let's say they give you 1 milligram per kilogram, 0.1 milligrams per kilogram, 0.01 milligrams per kilogram, and let's say they give you a one-off and they say what do they say they give you? Let's say they give you the amiodarone dose, 5 milligrams per kilogram. And you're sitting there trying to figure out, like, hey, which one is it? Any pediatric dose where they give you options like this, if you do the math, I guarantee the answer will pop out. If you do the math on all of them. So, what's 1 times 10? 10 milligrams. That's obvious. It's not it. What's 0.1? I have a 20-pound kid. That's a 1-year-old. All right? 0.1 times 10. 1 milligram. You think a 1-year-old gets, let's say this is a 1-year-old. You think a 1-year-old is going to get the full dose?
And that's the max dose.
The max dose would be it will never go over the adult dose. All right, 0.01 gives you 0.1 milligrams, which will be 1 milliliter, right? Of the 1 to 10. And then 5 times 10 would be 50 milligrams. That's obviously not it. The right answer will appear. It works for adenosine. It works for anything. The only thing you have to remember on pediatric dosaging, like, it will always be the 0.1s, 0.01s, stuff like that. I gave you a way to remember that for the atropine, 0.02. The other thing is amiodarone. Amiodarone is 5 milligrams per kilogram across the board. So if you're doing BFRS, it's 1 milligram or 5 milligrams per kilogram. But as long as you know that this is always just my rule. Another rule for pediatric vital signs. Okay? This is just things that I've created to help it eat. I'm literally at your level. I have to think of ways. I have to minimize. There's so much you have to know going in there. I have to put stuff in boxes and have an easy way for me to remember it, and also a way for me to construct it in my head and go, okay, I'll use this method and no one else. All right, so pediatric vital signs. Let's look at an adult. All right, so you get your PD, and you got your adult. What's a normal heart rate for an adult?
200.
Give me a normal blood pressure, 120 over 80? And what's a normal respiratory rate? 12 to 20?
Yeah.
All you need to know is the beginning and the end. Pediatric. What is a newborn heart rate?
160.
140 to 160? All right. You want to say 70 pounds?
Yeah.
Because it's 2 times age?
I just pulled it up on here. It says newborn, so probably 0 to 3 months is 80 to 205.
What?
100.
What? Heart rate?
Beats per minute.
Oh, when they're born, like normal.
Oh,
It can be, so, do you know the 220 minus your age deal? What does that mean to you?
that's the max your heart rate.
That is the max sinus rhythm. So, let's do an example. I'm 47 years old. I go do a sprint workout with you young bucks. You know what I mean? Y'all are killing me. And you put me on the monitor, and my heart rate's tacky. What would be my max normal sinus rhythm, sinus tach, before you start thinking, oh, this could be an arrhythmia? What's 220 minus 47?
173.
173. So if you put me on the monitor and I was tacking along at 240, is that sinus tach or is that an arrhythmia? All right, that's how you use that. Like if you put me on the monitor and my heart rate's 170 and I've been doing all this exercise with y'all because I'm trying to keep up with y'all, guess what? That's just sinus tach. Because you have an explanation. I was doing vigorous exercise and sprints, and I go, I know up to 173 could be sinus tach. You would not put me at SVT, right? And we'll kind of go over this with tachycardias, like that. But just trying to explain, like, hey, we had a pediatric overdose. A great example of this. Have you ever heard of a what's the other name for parasympathetic? All right. Have you ever heard these phrases? Hot as a hare, mad as a hatter, blind as a bat, like that. So, it's called the anticholinergic syndrome. It's the opposite of sludgem. Sludgem, you give an anticholinergic, atropine, to dry up the secretions and stuff. What if you overdose on something that dried you out? That's the anticholinergic syndrome. All right, it's the opposite. It's like overdose on atropine. Do we go around running an overdose on atropine? It happens to kids a lot because when kids overdose on something, if they don't have access to narcotics, what do you think kids try to kill themselves with? No, don't think trauma, think pills.
Like ibuprofen, medicine cabinet.
Mom or dad's, but what's in every medicine cabinet? Tylenol, ibuprofen, Benadryl. So they use over-the-counter medications, common medications. Now, if you overdose on Tylenol, you're going to kill your liver. Because that's where it's processed at. If you overdose on ibuprofen, you're going to kill your kidneys. Because NSAIDs are processed in the kidneys. If you overdose on Benadryl, this is where it's going to fit in the anticholinergic system. Because what does Benadryl do? It dries you up. It's an H2 blocker. So this is like the most common scenario. So you would think somebody took 100 Benadryl. How would you think they would appear? Not good. Exact opposite. They are wound the fuck up. This is the anticholinergic system because it dries you out. So the whole, mad as a hatter, dry as a bone, red as a beet, tachycardic, blind as a bat. What did I tell you, atropine? They put the drops in your eyes whenever you go to the doctor. It dilates, so your pupils are going to be dilated. So you're going to be blind as a bat. If it dries you out, are you going to be able to sweat? That's why you're dry as a bone. All right? Now, if I can't sweat, can I get rid of heat? So what does that do? Cranks up your body temperature. So what happens if you're doing the sauna, what color do you turn? I turn the same color. I turn red. So you're red as a beet. All right? And if you can't sweat, like that, it's going to make you tachycardic. All right? So we had this kid that took 100 Benadryl. You don't think anything of it. I do this all the time. So like I pull up as EMS 1, I say, hey, I was just delivering their equipment. And I asked the driver, I said, hey, what do y'all got? And he goes, because I've ran on this before plenty of times, because this is like a 16-year-old or a 14-year-old overdose on over-the-counter meds. So what do y'all got? He goes, it's just like a Benadryl overdose. I go, ooh, that sounds interesting. And I run over to the deal, go open the door, and I look at the guy that's like the super medic, critical care. I went through critical care with him, and I look at him, I said, tell me this. I said, how mad is he? And I go, how tachycardic is he? And he goes, he's pretty pissed off. So he's agitated. And I go, and he looks at the monitor, kind of puts his eyes on the monitor, and I peek around, and I go, this son of a bitch is 14 years old, he's tacking along at 196. Now, all the other medics in the deal are brand new guys, less than 2 years. What do you think they're thinking? They're thinking this son of a bitch is an SVT, because it says SVT greater than 150. It doesn't mean greater than 150, they fall into this category. Just like I was exercising, I can get greater than 150. It doesn't mean I'm an SVT, VTAC, or AFib. All right? And I look at it and I just go, I said, how many of them are one to, I said, give adenosine. He goes, they're discussing it right now. He said, he's letting them do it. And I go, okay. This leads to seizures, by the way. And so you got to be ready for seizure medications and stuff like that. But he's all dry as a bone, mad as hair. He meets all the criteria. There's like a whole deal. If you Google it, anticholinergic toxidrome, if you Google it, it shows the Mad Hatter. Do you know why, just so I can be old and y'all can prove how old I am, do you know why they call it the Mad Hatter? Do you know what the Mad Hatter's from? All right. Do you know why the Hatter is mad? Because when they used to make felt caps, felt hats, they used mercury, and they would get mercury poisoning, and they would go mad. Just a little history deal for you. But that's why it's the Mad Hatter. So they're agitated, they're pissed off. All right? But they're pissed off, tachycardic, dry as a bone, red as a beet, and they will give you this on National Registry. And then it's like, oh, but this is expected with the Benadryl overdose. This is actually expected from any kind of overdose on Benadryl or what's the shit called? The motion sickness stuff. Dramamine, meclizine is another one. Any kind of vertigo meds, because they dry you out. But any kind of antihistamines, they dry you out. So if it's antihistamine and they overdose on it, expect this. All right? But that's what I was getting at. It's the 220 minus age. He's 14. 220 minus 14, he was at 196. He could be up to 206 and be sinus tach. Now, if you have grandma that's tacking along at 160 and she's 80 years old, what's 220 minus 80? 140. She's tacking along at 160. Now, is that sinus tach or is that a arrhythmia? There you go. That's how you use the 220 minus the age. Okay? But going back to the deal, 140 over 60 is a normal newborn heart rate. SVP, let's call it 70. Their respiratory rate is usually anywhere from 40 to 60. They're breathing pretty fast, right? Little bitty lungs, everything circulation. So this is 0, and let's call this 12, because we'll say that's puberty. Or you can say 18, whatever. Now, you give me a 6-year-old, and I go, I know that this heart rate eventually works down to this range. I know this BP eventually works up to this range. I know that these respiratory rates work their way down. So if you look at a 6-year-old, let's just say let's make this 150. And we'll say this is 80. Now look at a 6-year-old, what's halfway there? If you had a 6-year-old and his heart rate was 110, let's say a BP of, 90 over 60. And let's say his respiratory rate, let's say it's 50, let's say it's 12, different for 40, let's say he's breathing at 26 times a minute. Now, in an adult, you might say that's compensated shock. For a 6-year-old, and they might try to get you there, they might say like this, 84 over 60. And let's just say they do a heart rate of 118. Those look like shocky vital signs. But a 6-year-old, that's expected. That's how I rationalize that. I look at it and I go, okay, somewhere in the middle, a 3-year-old I would expect here, like this. What they're trying to do is trick you and make you think they're hypotensive. Same thing with the pregnant woman. You know what their blood pressure does during pregnancy? You know what the heart rate does? So if I give you a 110 and they were 94 over 50 and they were in their 3rd trimester, you might go, oh, they're in shock. That could be normal vital signs. You know what I mean? So that's how I rationalize it when I go through the test. I go, I know what the bottom is, I know what the top end is. I know what the trend, which way it trends. It's either up or down to get to that normal adult range. And then I just try to figure out the middle. It may take me a couple of, if the answer doesn't pop out to my head, like obvious, I go, I just do this and that's how I work it out. But they're going to give you something like that and make you think. And with an adult, it'll look hypotensive or it'll look something. They're not adults. So, them, a heart rate of 90 might not be, or a heart rate of 110 might not be a big deal. Does everybody kind of get that? All right. So, pediatric bradycardia. Again, try airway first. If it's still be aggressive with your airway. Quick treatments. If it doesn't reverse it, we go CPR, but we still do our bradycardia things. Epi is the same dose of cardiac arrest, 0.01. The reason why I say that we're still doing bradycardia things, do you do atropine for pediatric cardiac arrest? Look at it. Is it on there? If you do the cardiac arrest, it's still on there? Couldn't remember if it's
Well, no, it's not.
pediatric,
Pediatric cardiac arrest.
but you don't see atropine on it. Yeah, because atropine is only used for bradycardia. Atropine only needs to go in bradycardia and like slipping. We don't use that in cardiac arrest. We use epi, but not atropine. And then TC and then pacing. If none of those work, then what do? Then you move to the pediatric cardiac arrest out of that. You good with that? All right. So let's go to adult tachycardia. You can take notes on these if you want. All right. So, that very first box says assess appropriateness of heart rate for clinical condition. Heart rate typically is greater than or equal to 150. So adult tachy. Your first indicator is greater than or equal to 150. Greater than or equal to 150. All right. Initial assessment and support. Maintain airway. Oxygen if hypoxic. Continued cardiac monitoring, IV access, and 12 lead. All right? Is the patient's tachycardia causing what? What are those 5 things? Hypotension, altered mental status, signs of shock, ischemic chest discomfort, acute heart failure. Now, for bradycardia, that means we can treat. For this, let me put one of those on each side. For this guy, this decides our treatment route. So, if we were to look at our Brady example, or a Tacky example, for this, Tacky, let's say, give me a rate for SVT. 220?
Yeah.
Does that work? All right. 220. Now, are they going to have the same stroke volume?
No.
Because it's going so fast, it's not going to be able to fill all the way, right? So a normal stroke volume for this would be 10 milliliters. Equals 2,200. Again, greater than 50% reduction in cardiac output. I'm expecting 70 over 50. I may get 140 over 90. So, if I get 70 over 50, or if I get 140 over 90, we're going to treat either one. What does it make a difference in my treatment? If I meet one of those criteria, I treat one way. If I don't meet one of those criteria, I treat a different way. So, meds versus electricity. So, if I meet one of those criteria, would you say your patient is more critical?
Yes.
All right. So this is your critical patient. And they go, so for this, it's going to be, I'm sorry, I was just using that to explain. If you do oxygenation and stuff like that, none of it fixes, then if they meet, if they meet one of these criteria, if they meet one criteria, you're going to sync cardioverter. Most likely, it's going to be your BP below 90.
I know an acronym that always helped me to decide if like they're symptomatic, and it's CHAD. So it's like, but it's like chest pain, hypotension,
Altered mental status and discomfort.
But it just helped me a little bit. And I'm also going to do it. Diaphoresis and dyspnea.
All right. I like that. So if they meet one of those CHAD criteria, or that up there, then we're going to sync cardioverter. Whether it's narrow or what? Wide. Whether it's VTAC or SVT, hey, or AFib. AFib with RVR. All right? If they meet one of those criteria, it says synchronized cardioversion. Sedate with whenever feasible. All right? I will tell you this right now. You're not going to have time to sedate. What does sedate take time to, what do you have to do? So if this patient is blood pressure is 70 over 50, let's say you might have time for a 12 lead, probably won't have time for an IV, slap the pads on, and tell them about the riding. It's okay. This happened to a Task Force 1 worker down in Harvey when we worked in the hurricane. He knew he had problems with, he would have runs of VTAC. And they have a doctor assigned as a medical officer assigned to those teams. There's a guy in Frisco, and he goes, fuck, he's like, I know I'm gonna be tacked. He's like, just check me out, something like that. And the doctor goes, pulls him back there. He's in VTAC, and he had a blood pressure of 94 over 60. So they start drawing up meds. They do recycle the blood pressure. You can tell he's getting more sweaty, more pale. He was 80 over. Came back as 80 over 50. He goes, sorry partner, we gotta do this. We're cardioverting now. Nothing for pain, nothing like that. Here's what you don't want to give a patient that is if they're hypotensive and on the edge, and you're worried about this cardioversion or pacing hurting them. What drug do you not want to give them? To sedate them. For session. Why?
Lower your blood pressure.
It's very vasoactive. So anybody that's shocking, stay away from Versed. What's a good drug for this? Ketamine. Ketamine, because they'll probably forget it. All right. Now, if they were narrow complex, if they were SVT and unstable, you could consider, it says, consider adenosine. But it says, what do you do first? What's in bold? Synchronized cardioversion. All right. It says, if refractory, underlying causes need to increase energy level. So usually we started ours at 200. You can go up to 300, 360, whatever. Or you could start with your medications too. If you can't convert them with cardioversion, then you could go with medications. All right. Now, if they don't meet one of the CHAD criteria, that criteria, and it's wide, what do you notice? What do you notice on the deal? Let's say it's in VTAC, but they're stable. Let's say they're 140 over 90, no altered mental status, no acute heart failure, no all of that. No, go to the right. It was VTAC, and it says yes.
But then it's sitting in monomorphic.
So if it's regular and monomorphic, that means VTAC. You could give adenosine. Now, what would be wide and polymorphic? No, it wouldn't be alive. No. Say it again. Torsades. Torsades is polymorphic VTAC. What does polymorphic mean to you?
Changing shape.
Yes. So we know from our torsades, the twisting of the points. It looks up and then it looks down, right? All right. So the way to remember, I always remember. So what drug do they need? Mag is an electrolyte. Polymorphic VTAC is sodium and potassium in an MMA5. Sodium's winning, we're up. Potassium's winning, it's down. What does Mag do? He's like the referee that pushes everybody back to the corner and hope that it returns to a normal sinus rhythm. This can get a little crazy. So look, if they're in VTAC but stable, or if they're in SVT and stable, go with adenosine. But the only other thing to add in, if they're in SVT, add in vagal inhibitors. VTAC, vagal inhibitors are not going to work. Now, if they're polymorphic, go with MAC. There's 2 doses of MAC.
2 and 4.
There's 1 to 2 and 3 to 4.
4 is for the eclampsia, preeclampsia 2 and
4 is for pregnant women. Lower dose is for polymorphic VTAC.
I remember because if they're pregnant, you think of 2 people, so it's double the dose.
Yeah. Good. I like the way I remember that. Honestly, we give like 4 to 6 in our protocol. But 4 for the pregnancy, 1 to 2 if they're in torsades. All right? And then you could go to amiodarone here as well. but you're gonna start out with adenosine on this test. In real life, it'll be adenosine. I mean, it'll be amiodarone. All right, let's say they're wide, or they're not wide, then it goes straight to, so if you have, so this, always, here's how I used to write it, see if it still applies. Where's my, oh, back in.
On the floor.
Alright. Let's see if this little cheat sheet still applies. We used to write it as stable and unstable. So, unstable. We used to do narrow, wide, and irregular. This is the old way of doing it. You tell me if it still applies. If they're unstable, if they're single, wide, or irregular, the cardioversion. Because it's usually going to ask what your initial intervention is. It's just the easy way to remember. If you're unstable, this is unstable. All this. They meet one of those criteria, they're unstable. We're good. This is the big one I remember. Because signs and symptoms of shock is usually because you're hypotensive, right? Altered mental status is usually because you're hypotensive. Ischemic chest discomfort is usually because you're hypotensive. And heart failure, I'll explain heart failure in a minute. But like that, rails or crackles. So if they're like that, we think cardioversion. If they are stable, no, why? The regular is the AFib. If they're stable, vagal, adenosine, or cortisone. So if adenosine doesn't work, you run through all your adenosines, it doesn't work, then we give cortisone, which is a calcium channel blocker. Alright? Only difference is I used to put amiodarone on here. You just go adeno and amio. If it was a regular, we would say calcium channel blocker, cortisone for that. So we can still apply this a little bit, just kind of as a shortcut. All right, so you have two options. It says antiarrhythmic infusions for stable wide QRS tachycardia. So if it's a regular, if it's adenosine, regular and monomorphic, you go with adenosine. And then your other antiarrhythmic infusions are amiodarone and procainamide. Did you learn about procainamide?
Sodium channel blocker, I believe.
It is. Did you learn about it? Did you learn about amiodarone? And just leave it there.
Yeah.
If you need to know what the other version of amiodarone you could use, would be procainamide. Hey, good luck on the dose. Hey, it's one question. You know what I mean? I know what I know, and I don't think learning a new drug at this point will work. You know, because I still have not seen procainamide on this test as an option. Everybody pretty much sticks to amiodarone. All right. Now, tell me this. when you're looking at antiarrhythmics, you got your SA node, your AV node, and you got your Purkinje fibers, right? SA node goes at what?
6,200.
6,200. All right. AV node goes at what?
40, 60,
And where your Purkinje fibers or ventricles go at?
24.
20 and 40. All right. Everybody's good with the electrical system, right? All right. Now, I want you to think about this. You might get asked a question about the cardiac cycle. So, cardiac cycle is 1 through 4. I want you to separate these into atrium for 1 and 2, and ventricles 1 and 2, 3 and 4. When you look at your, can I erase this part? Right. When you look at your cardiac meds, and how they work, and you're looking at, let's say, here's your heart, here's your atrium, these are your ventricles. Calcium channel blockers and beta blockers work better on atrial arrhythmias. Think about it. If you have somebody in AFib, or if you have somebody in some kind of atrial tachycardia, a beta blocker or a calcium channel blocker is usually what they'll give. If you have somebody in AFib, they're going to put them in that. If you have somebody in a ventricular arrhythmia, tachycardia, usually they'll give them a sodium blocker or a potassium blocker. Because potassium channel blockers and sodium channel blockers work better on ventricular arrhythmias. That's why procainamide, what does amiodarone do? Quit thinking about it right now, just be with me for a minute. What does amiodarone do?
The calcium channel blocker.
It is so the reason why they came out with amiodarone, they thought it was going to be the end all, because it's supposed to be a calcium channel blocker,
Yeah, everything.
a sodium channel blocker, and a ventricular or a potassium channel blocker. It's supposed to be all three, and so it's supposed to work on any arrhythmia, any tachycardia. That's the whole goal when it came out. That's how they sold it. What they found is it's more of a potassium channel blocker. It does that really well, and it does the other two kind of well. Does it make sense? Mm-hmm. All right. Lidocaine is a sodium channel blocker. Procainamide is a sodium channel blocker. All right. Now, when you were looking, again, your whole dendrite, the whole sodium-potassium pump, how many potassium on the inside? You have 2. You have 3 sodiums on the outside. National Registry-wise, they'll ask you, what's the dominant extracellular cation? So, what's the dominant intracellular cation?
Potassium.
All right. What starts this process? The calcium influx. If you were to think about this as 1, 2, 3, and 4, just like I said up here, that's why calcium works better on atrial arrhythmias. If you think about it starting at the top, like the ACA note, that's why it works better on atrial arrhythmias. Because if we stop the influx of calcium, the goal is it will slow down and go back to a normal sinus rhythm, a regular rate, right? Now, what happens to start this process is the massive influx of sodium through those sodium channels. And then potassium goes to the outside through those potassium channels. That's why a sodium channel blocker will slow the influx of sodium into the from extracellular to intracellular, and goals that it will reset. If I can slow the influx, then it might slow and knock them out of ventricular arrhythmia, that tachyarrhythmia. If I can slow the efflux outside the cell for the potassium, again, it might reset it. Does that kind of make sense? Because what happens is sodium goes in, the potassium goes out, it changes the polarity of the cell, it depolarizes, and the message keeps going, right? What's special about cardiac cells?
Automaticity.
Say that again?
Automaticity.
Anybody ever seen Backdraft?
Yes, sir.
You go, we all go. If you get one to go, the rest will follow. So, if I can slow down that process at the beginning here, then it might reset. The goal is to reset the electrical. It's like flipping or doing a GFI. You ever have those GFI plugs where you lose power and you hit that deal and it resets? That's what you're trying to do here. You're trying to hold it long enough so it can reset and go back to a normal rhythm. Right now you're in a ventricular arrhythmia. If I can slow it down right here at the ventricles, that's why it works better on ventricular arrhythmias. I can slow it down. The goal is to get it, if they're at 220 and it slows down, 60, and the goal is to kick back into where the SA node is your dominant pacemaker. That's what, if your SA node is your dominant pacemaker, you're in a sinus rhythm, right? Mm-hmm. And we know that by what? Upright P waves. All right? Now, tell me this. During SVT, do you know what SVT is?
Yeah, it's just,
Does anybody have SVT? All right. You have an alternate pathway. All right, an alternate internodal pathway or whatever. That goes down to the AV node. When it gets excited, it becomes the dominant pacemaker. And it'll fire you off into a tachycardia and you'll be at 220 or heart rate will be 220 or 190 or whatever it is. You with me on that? So, when we give adenosine, where does that work at? It's an AV node blocker. Adenosine, if you look up the definition of adenosine, it's an AV node blocker. It only lasts 6 seconds. It actually lasts 10 seconds, but you got to get 4 seconds to get it there. That's why we do the rapid push. And we try to go through AC. We push it, we get it, it starts slowing down. It either kicks back into SVT or it goes into a normal sinus rhythm. We're trying to break that rhythm because we're going to hold the message there at the AV that it'll stop listening to this one and start listening to its old bill. We have an alternate road. It's, it's kind of like when somebody comes in there. And we all work 911, right? Have you ever met somebody that comes in there? Like, our whole goal is to de-escalate, right? Have you ever met that asshole that comes in and just escalates everything? Mm-hmm. And then now you're stuck in a shit situation and you're trying to get out of it and all that other stuff. That's what SVT is. Your whole goal is to reset everything like woosah, let's get everything calm, and your goal is to be the adenosine. Let's reset, let's get this guy out of the equation, and let's go and let's get everything calm. You know what I mean? Let's de-escalate this a little bit. Usually it's a cop that does it, and there's a time and place for that. But cop does it, it's like, hey man, we're good. We got this guy, and it happens in the jail all the time, because the jailer doesn't want to be sitting there, and we're just like we're trying to be good patient advocates. And I was like, okay, here, let's do this, do that. And he goes, hey, is he going or what? You know what I mean? And then all of a sudden, everybody gets riled up. We want to keep everything calm. We're trying to be the adenosine situation. Okay? Now, you understand that, and you understand why we give adenosine. What's one condition that we do not want to give adenosine for?
Wolf Parkinson White.
All right? How are you going to know they're Wolf Parkinson White?
There's
Jason.
J-wave is for hypothermia.
I thought it was a delta.
That is called a delta wave. Another way they will describe it is a slurred up stroke. If they say a slurred up stroke on the QRS, then that is delta wave. Here's the problem with WPW. When it gets activated, and here's what WPW looks like. It's an extra pathway too, but it bypasses the AV node. All right? It bypasses the AV node and it puts them in a tachycardic rhythm, just like SVT. And it looks narrow, because it's coming above what? Above the ventricles, right? So it looks narrow. Now, you're not going to be able to see a delta wave when it's tacking along at 220. So how are you going to figure out it's WPW? You got to ask them at their history. Now, I know there's a guy at Station 5A, he's a captain. He has WPW. Well, we're just doing an EKG like normal. If I was to put him on EKG, just sitting there watching TV, and he's at a normal heart rate, I'm going to see that all day long. I'm going to see those delta waves. He sees it every time he goes in for a physical. Right, oh, you got delta waves. Yeah, you know you got WPW, you go, yeah. All right? But when he gets activated, you can't see it because it's so fast. You understand what I mean? Like, it's so fast, you're not going to be able to see it. Just like if somebody's AFib at 220, it's going to be hard to see that it's irregular. They use adenosine a lot to diagnose AFib as a diagnostic tool, because it only lasts for 6 seconds, right?
Yeah.
So if it lasts for 6 seconds, slows it down and go, oh, that's AFib, let's do Carson. We did that in the hospital all the time. Now, the reason why you don't want to give adenosine to a WPW patient is because you're killing their backup electrical system. That AV node is their backup. You're not fixing the problem, you're taking away their backup. Does that make sense? So it could or could not put them into cardiac arrest. It did for one of our students here. He actually still works here.
Campbell.
Yes. Cheeseburger. So Cheeseburger was a student here. He was 3 weeks in. All right? He's 3 weeks in. They go outside, and I swear to God, like all the friends from Midlothian, they decide to go to fire school and EMT and paramedic school at the same time. So they're all buddies. They go out there and they're playing flag football on Friday. He's got a date later that night. He goes, all right, guys, I'm done. Go to the house, shower. His heart rate wouldn't calm down. He's like, man, something's wrong. And so he takes a shower, tries to fix it, and he's like, okay, like I'm still feeling my heart beating out of my chest. And he goes, okay. He goes in there, tells the girl, no date, tells his dad, said, hey, there's something wrong. And he's like, I think we need to call the ambulance. And his dad goes, hey, ambulance is for sick people. I'll run you into the hospital. Runs him up to the hospital. His heart rate's like 240. They send him straight back, just like any tachycardia. The straight back is like, hey, let's get him back to a trauma room. Put him in a trauma room. It's narrow complex. It's fast. They give him the adenosine. He codes. He codes. They shock him twice. They get him back. He had WPW. They go up to the ICU. We see him the next day. We're all up there, all the students and instructors. We go up there, you know, because it's like a serious deal. We want to make sure he's okay. And he tells me the whole story. And my first thought, dark humor, I said, man, I bet your dad feels like shit. And he goes, yeah, look at him. He's over there just white as a ghost, like not saying anything, just like, and so like, he throws it back at his dad all the time. He goes, he said, he was like, hey, we got to take your sister, like, everything's go to the hospital now. And he was like, hey, he's like, we need to take your sister to the hospital. He goes, we need to call an ambulance. He goes, Dad, now ambulances are for sick people. And he goes, shut up. And he gets pissed. But that's why you don't give adenosine. Here's why you don't need to feel bad. You just need to remember before you do it, say, hey, you got WPW. You're not going to know unless you ask. Because what you're not going to see while they're 240 delta waves. So you need to ask them in their history. Now, the code red brain, shock them. That's why you need to have the pads right there. That's why the pads need to go on there, Brady, Tacky, and AMI. Put the pads on. Alright? But that's the reason why you don't give adenosine to WPW. Because a lot of students always ask, they don't know why. It's because it bypasses the AV node. It's an AV node blocker, you're taking out the backup system. Now, it can not work and not kill them. I guarantee you, we've probably given it to a lot of people that have WPW, no big deal, but it couldn't. Does that make sense? All right. Now, but I just want you to understand why we give calcium channel blockers to atrial arrhythmias, why we give sodium potassium channel blockers to that. Beta blockers are for atrial arrhythmias, stuff like that. Not go too far into it. And, everybody understand the whole tacky while we're treating, while we're trying to be aggressive with it and all that? All right. Let me know if I go too much. All right. So now do we need to take a break or we're gonna do atrial or pediatric? All right. I'll tell you what time is it? Take 5 minutes and we'll finish up for lunch for pediatric. Take a quick, This is why you gotta know your 220 miles ready. What is an infant? 0 to 1 year, right? So what does it say right here? It says infant greater than 220. On pediatric, it says, like adult says greater than 150, pediatric says greater than 180. All right? So, what does it say at first? Initial assessment. Maintain airway. If there's positive pressure ventilation, if we need to do ventilation or oxygenation, we do it right there. And we can start our IV access or whatever, put our pads on. Do your initial rhythm. And let's say you got an infant at 240. Or let's say you got a 5-year-old and it's 240. They meet the criteria, right? Now we just got to figure out if there's any cardiac pulmonary compromise. I always put that if there is, they're unstable, and if there isn't, they're stable. So this left side of the deal, that is your unstable. I'm going to go through this. I'm not going to put this on the board. So, if they're unstable, which they meet one of those criteria, what did I tell you they're going to give you? Cap refill what? Greater than 2 seconds. All right? That's one of the big ones they're going to give you. If it is SVT and they're unstable, but you already have an IV established, you already have access established, what does it say you can do? So what do you think it says, or synchronized cardioversion? So if you have an IV, do adenosine. If you don't have an IV, that's all that's saying. If you have an IV, you can do adenosine. If you don't, synchronized cardioversion. Now, both those answers are not going to be on there. It'll just be one of those answers because it's in that box, this or this. But that's how I read it is, if you have an IV, give them adenosine. What's the dose for adenosine?
0.1.
This is pediatric.
0.1 milligrams per kilogram.
All right, go do my little trick. Here, you go do my little trick on the board.
Oh, goodness me.
Hey,
You know how to open a marker?
you have a 60-pound patient, and I'll give you 3 options. It's either 1 milligram per kilogram, 0.1, or 0.01. All right? What do you know the adult dose to be? What's the first dose?
6.
All right, so you know 6 is your top end, right?
Mm-hmm.
And I got a 60-pound patient, so how many kilograms is that? 27.
27.
All right. So what's 27 times 0.1?
2.7.
All right. What's 27 times 1? So it ain't 27, right? There you go. What's 27 times 0.01? Now, 60-pound kid, I told you an 80-pound kid is the top end of the deal. So that's almost an adult.
Yeah.
Do you think we're gonna give them 0.27?
No, I won't do that one.
That's like, what? That's like less than, that's not even a tenth,
Yeah.
the adult dose. That's like a 20th or 100th, something like that. All right? There you go. 2.7.
There you go.
It is 0.1 milligrams per kilogram. But
The more you know.
it's just to show you how to use that deal to rationalize it.
Okay.
All right, so if you have an IV, if they're unstable, if they meet one of those criteria, if they're unresponsive, if they have a cap refill greater than 2 seconds, and it's it's SVT, if you have a line, give them a Denison. If you don't, cardioversion. Now, what does it say cardioversion starts with?
0.5 to 1 joules per kilogram.
All right. If it doesn't work, you can give them.
2
Two.
joules.
All right. So, what would be, if it was one, let's say if they wanted to give you a 1 joule, you're looking for that one, you're looking for 27 or 13.5. Somewhere in that range. Because that's 0.5 to 1.
Yeah.
All right. Just how you got to think about it. Like when you figure out the deal, it's like, oh, man, so it's 0.5 to 1 or 2. That's just something you got to know. All right. Now, if they're in VTAC, we'll go straight to cardioversion. Same dose, right? 0.5 to 1 or go to 2. All right. Now, if they are stable, they don't meet any of that criteria, and you think they're SVT, they treat it just like an adult. Bagel, give your adenosine. You know your dose. Here's where the issue comes in. They don't want you giving, it makes it easier on you, they don't want you giving kids any other. So what do? If it's in VTAC, if it's monomorphic, give adenosine. Otherwise, what does it say do? Consult a doctor. So, they're probably not going to give you a VTAC stable. If they do, it's adenosine. If they give you anything stable, any pediatric tachycardia is stable, what do? There you go. That's how you simplify it. Make that box and go, okay, just adenosine. If it's unstable, with cardiovert, unless it's SBT and they have a line established, then we give them adenosine. So if I was going to pick a drug, if they give me 4 drugs to pick, no matter if it's unstable or stable, they give me 4 drugs to pick from, and I know that this is a tachycardia, he's at 240, and I know they want me to give a drug because there's 4 drugs on there. All you're looking for is adenosine. Does that make it simplified a little bit? Okay. All right. Now, let's see if we can get to. See if we can get through. I don't think we can do it. I think we'll do cardiac arrest when we get back. All right. Questions over anything so far? 1 o'clock? Wait. It does feel good. Let's not do it. Yeah, but the FPP is greater than 90. Now, greater? It has to be greater than 90.
Oh, okay.
Because it's a vasodilator. Remember, it's not an analgesic. It's a vasodilator. It dilates coronary artery vessels, and it does what? Reduces preload. All right. Now, yep. How long? I've heard multiple, but I've heard between 24 to 48 hours. It is 48 hours. If no ED meds in 48 hours. Now, they're not going to give you the brand name. They're not going to give you Viagra. They're not going to give you Cialis. I don't know what the others are. All right. But just like our LOLs, our Zenmilpine, and our Prills, they all end in the same thing. You know what the other name is for Viagra or Cialis? It's sildenafil.
Yeah.
So it's like this. It might be AFIL, but they all end in FIL. So if you're in a chest pain scenario and they give you a list of medications, you're looking for FIL. And how you're going to remember that is it's an ED med because you're going to fill her up with your engorged penis because you took a vasodilator. But that's the danger in giving nitro. Because what are you doing? You're stacking vasodilators. So what's going to happen? And the ED meds they give now, they last up to 48 hours. Like they will tell you not to take, they will tell you to take whatever the dose is and don't add any more of that in the next 48 hours because it will work, it will stick around and work. There are studies they're doing right now for tadalafil or tadalafil, I can't remember, it's alafil. Anyway, Cialis is actually showing benefits, long-term benefits in short doses, like 5 milligrams a day, and for cardiac, and also for prostate health. So these drugs are going out everywhere. So guess what? The frequency of them is people are going to be using them. You know what they prescribe you at low T centers? Tadalafil. You know what you end up with after you're taking low T for a long time? You end up on CPAP. You know why? You know why they treat all these things at low T centers? Because low T testosterone treatment causes it. What does testosterone treatment do? Yeah, I'm saying this because there's a lot of dudes on testosterone. All right, me being one. Huh? No. So how testosterone works? Number one, it thickens your blood. So there's a key blood factor we look for. We look at hemoglobin, but we also look at, so like for women that have women get like blood transfusions that have like really bad periods. You know what I mean? They can get anemic or low blood. That's your hemoglobin. That's a low count. So when they say, hey, their hemoglobin was down to 6, you know, in a woman, I think it's less than 7 meets the criteria for a blood infusion. When they talk about hematocrit, that is your thickness. Think about it. It makes you produce more red blood cells. You produce more red blood cells, your blood gets thicker. But we have to go in and bleed like every so often to keep our hematocrit down because it can cause hypertension. Yeah. What happens if you produce more red blood cells? It thickens up your tissue. And if it thickens up your tissue, what is muscle tissue? Makes you look bigger and everything. But guess what? It thickens the tissue around your neck too. And it gives you sleep apnea. All right? So if it gives you sleep apnea, then you're going to end up getting CPAP treatment. So they go, hey, we got these treatments for CPAP, for sleep apnea. It's because the shit we're giving you causes it. Make sense? And if the thicker your blood flow is, the less it flows smoothly in areas where you might need it. Hey, we got treatment for that too. We got vasodilators. They'll help out with veteran stuff. You know what I mean? So all the treatments you're getting, all the side treatments that they give you, it's because of the first treatment. Cause it. And there's a lot of dudes that take this stuff. So you need to include that in your question bank. Sit there and go, hey, do you take any ED meds? Especially if they look like, hey, you know how you can tell dudes are on testosterone with their blood's real big? You ever heard of red ass? If they're real red from here up, they need to go dump. And they need to go get blood. All that other stuff. And if you don't think, find a testosterone clinic and find how many dudes are running in and out of there. It's like a puppy mill. I promise you. Synergenics and McKinney, already got 80% police and fire clientele. Like, we just high-five each other on the way in and out. It's like no big deal. All right? So, no ED meds, no pills in the last 48 hours. What's the other one?
Inferior MI.
Nope. Inferior MI is not a contraindication. I'll show you in a minute. All right. It's heart rate less than 50. If you're having chest pain and your heart rate is less than 50, is this the algorithm you need to be in?
No.
What algorithm do you need to be in?
Brady.
Has anybody ever seen Tommy Boy? Yes. You're in the wrong map. Get yourself in the map. You're in the wrong algorithm. You need to be in bradycardia. Like, to me, it's a stupid contraindication because if the heart rate is less than 50, I go, I'd be in bradycardia, I wouldn't be over here. But they say the magic word chest pain on the test, and y'all don't see a patient with chest pain, y'all just see a test question. Oh, this is chest pain. You didn't even pay attention if the heart rate's 40. If the heart rate's 40, you need to be in the bradycardia. Now, morphine. Really, the only contraindication I'd say is heart rate, BP less than 100, but not everybody, usually it's 100 for that or fentanyl. The big deal is pain management. We don't always use morphine. Morphine is great because it is also a vasodilator. But people use fentanyl, whatever their pain management protocol calls for. Why do we want to give them an analgesic? Think about it. If somebody's having a heart attack, why would you want to ease their pain?
Less myocardial.
I want to reduce their myocardial oxygen demand. Because if you're in pain, what is your heart rate response?
What's up?
Increase. And so I'm increasing the myocardial oxygen demand to a heart that's really already failing. So what do I want to do? I want to reduce that. Does that make sense? All right.
I had a question. I think I was taking on prep, on pocket prep. I don't know if it was on that or AVMs. That it asked, you have a third-degree block, your patient's unconscious, and you start pacing him, and he wakes up. Well, would you stop pacing?
No.
Would you give him? Oh, the other thing was that like they're allergic to all the pain meds you have on board with you. What would you do? Like, will you stop the pacing? Will you give them epi and then give him the pain meds?
Or tell them to
Oh,
suck
you
it
just
up.
tell them to suck it up and you just keep pacing them.
No, you manage it. You manage, if they're hurting, you can give them a little pain management. But, huh?
This is allergic to all the pain meds you have on your box.
Give them some Benadryl.
And then suck it up.
Yeah, suck it up. Because we don't need to turn the pacer off because what it's doing, it's working.
Yes.
It's got their blood pressure up, which jacked up their mental status. Everything's working.
It's just gonna suck.
I'm not going to give epi because guess what? It's working.
Yeah.
If I fixed it with that and I can't do anything pain management wise, yeah, like suck it up.
Yeah. I was like the other,
Stupid question,
like
because
the
a lot of
other.
us have so many different pain management.
Yeah.
Like you could even give IV Tylenol. I said it. That'd be a acetaminophen.
Yeah. But it's like I'm like I'm not gonna give him something for just that, you know, just like.
That's where you gotta, it's a stupid question, but it's where you gotta use, like, you knew the answer.
Yeah.
Everybody here knew the answer.
Yeah.
But you were sitting there going, I don't think that's what they think is the answer. Don't do that.
Okay.
Just use your common sense and go, hey, it's working. I was like, if I can't do anything, no sedation or anything, then I'll go, sorry, bud. You know what I mean? I don't know what to do for you.
What if they start ripping it off?
Huh?
What if they start trying to rip it off?
Restraints.
With restraints on, I'm saving your life.
You don't got a choice.
Like I said, we could play the what if game to death. You know? What if they, have a blah, 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 you know what I mean? You could, what if that's death? But yeah, if you put somebody on a pacer and it's working, and they come back and they have good mental status and everything, they're like, ow, 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 no, this hurts, and go, okay, give you a little something for that. But I'm definitely not turning the pacer off. Once they're on the pacer, they're on the pacer.
Mm-hmm.
I do not want to lose that. So if I start losing capture, what do you do?
Yeah, increase it.
Start turning it up. Alright, so morphine, usually it's like blood pressure greater than 100. But they may say fentanyl, that's another common one. Like something like that. But if they ask about it, the reason why we do it is to reduce our myocardial oxygen.
So for those contraindications being like these test questions, is that for every medication or more like the ACLS meds?
it could give you, I would say for the other meds, it would be like the common stuff, like, I don't know if they'll ask you this, but like sodium bicarb and calcium, you can't mix in the same line. You can use in the same line, you just have to flush in between. It's just because when it mixes together, it can cause
Crystal.
chalk.
What's the
They
one?
say chalk, it gets cloudy. And it can clog up the line.
What's the one that crystallizes?
That would be those.
That one.
Yeah. But
Crystal.
I'm trying to think of any other meds that have.
So, Solumedrol can cause seizures. Solumedrol can cause seizures.
Oh, I thought you did something else.
Like, I'll give you another one. Sucks. What's a deal for sucks?
Let's see.
A contraindication. So it's hyperkalemia. Alright? So, how would you know they're hyperkalemic? You can see PT waves. Use rock. Use bag. Use a different paralytic. Here's the one that comes up commonly. Burns. Burns can get hyperkalemic. The hyperkalemia doesn't happen until 24 hours later. So if you drag a burn patient out and you're going to put them down on RSI, you're totally safe with using sucks. If it's acute, less than 24 hours, you're not going to get that shift, that potassium shift, until 24 hours later. So don't worry about it. Yeah, I've had guys in the field go, we can't give sucks because it was a burn patient or whatever, and I was like, you're safe. That didn't happen. That's literally from the burn doctor at PHTLS I listened to, and he goes, yeah, it doesn't happen until 24 hours later. So you're totally safe with using sucks. But it could happen with other meds. I would say use common sense, like a contraindication that, all right, amiodarone slows down your heart rate, right? So what do you think a contraindication of it is?
Heart rate.
You know what I mean? Some of the contraindications are obvious. Just think of what the medicine does and then try to rationalize it out that way. But for these, there's test questions that lie all within that. All right, so without sliding too far off course, actually I can erase this now. All right, does everybody know their 2 period? Inferior, lateral, all that good stuff, greater 1 box elevation. I don't have to worry about that, right? So like if you had elevation in B1 or B2, B1 through B3, what would you call that?
Interior.
Septal,
Anterior.
anterior, or anterior septal. But it's got to include both of those, right? Those are touching. All right. What if you had elevation in B4 through 1, ABL, B4 through B6?
Bilateral.
I forgot you were doing that. I was so.
Do what?
All right. 1, ABL, B4 through B6.
Lateral.
Who said it?
Cody.
Anterior lateral? That's what you call it.
It's a
Because
C.
B4 is anterior, B5 and B6 are lateral. It's touching those, and 1 and ABL is lateral.
I need to see it in
The
front of
lateral
me.
ones are
I don't know
circumflex.
what you're talking about.
All right.
The lateral ones are circumflex.
So I'm going to try to help. I'm going to try to make this good enough. I'm trying to remember if I did it. All right.
What is up?
Does anybody know 2 or 3, which one on the left and right? Anybody pull a Minotaurus triangle?
The what?
Minotaurus triangle?
No idea.
It is. Which one are you looking for?
Which one, which side's 2 and which side's 3?
2 is right.
Left.
Hmm? You're right, there. Three is left.
Like I said, 2 is left.
Yeah,
2 is right.
yeah. He did it right up there.
This is very helpful.
Mhm. I got that. It's actually more helpful than a lot of other ones.
It's working pretty good.
Oh, is it?
Like it has videos and everything.
Yeah, it's like $15.
Found it on TikTok. This guy gives you different questions. Nice and great.
Well, you want to be 2 are next to the sternum, so ask for 6. You want to be 2.
Do I need to know this? I really don't want to learn something else.
2 and 3, because that just reminds me.
Sometimes it has too much.
F, ball,
Or it's kind of secluded. Which are secluded? I think it's like Sally,
I'm sure there's an
RCA,
easier way to remember it.
RCA, LCA. Right here.
I'm sure there's an easier way to remember it.
Here it's like, it's Sally, it's like the leg, like the left anterior descendant, left anterior descendant, and the next circumflex.
Mm-hmm.
And then RCA is 2, 3, and negative. So it's like LA, RCA is Sally. That's
Alright, that's
easier.
the best I can draw it. That's your septum. Here's where your heart's on. When you're looking at 12 lead, all you're looking at is cameras. You're manipulating cameras like that. Now, the way these cameras look are always, so you have, if it asks you a question, it'll have, so it'll give you, it'll give you a pick 3 on National Registry. And it'll say which one of your bipolar leads. Which ones are they?
1, 2, 3.
That's it. 1, 2, and 3 are your bipolar leads. So these, again, they have a positive and a negative end. The way they're going to be looking is always to the negative side. So your 2 and 3, the negative are at the top, that's always going to be looking up. So the reason why your 2, 3, and ABF are your inferior leads is because they're looking for the bottom of the heart up. All right, now, here's the deal. If you get elevation at 2, 3 ABF, can you tell whether, or by the way, this is your LAD, left anterior descending, this is your circumflex, this is your left main, and this is your RCA. All right, just by looking up the bottom, and the heart might be conducted a different way, just a little bit more rotate over. Does it know whether I'm looking at the LAD or I'm looking at the RCA?
I can't see it.
Yeah, because the left heart is the more dominant anterior part showing. Every part of your 12 lead, we're looking at the left ventricle. Do you know why we're trying to look at the left ventricle?
Because that's where the squeeze goes through the.
That's what pumps out to the body.
Yeah.
That's where we're going to have it's not the supply side, it's the distribution side.
Mm-hmm.
That's where we're concentrating. When we do a 12 lead, we're trying to figure out if there's anything wrong with the left ventricle. Because if the left ventricle is damaged, then our cardiac output goes to shit. Then our BP goes to shit. All right? So like when they say somebody's having the Widowmaker, that's a high left block. It's pretty much taking out the whole, it could be a high LAD, or it could be in the left main, but it's taking out the whole left ventricle. That's why it's called the Widowmaker. 100% blockage, you go down. Quick. All right? Now, 2-3 AVF is looking up. That's why an inferior MI is not a contraindication to nitro, because we don't know if it's a right side or left side. BP is a contraindicator. Now, if I had a right-sided MI, how do you think my patient would present? Either bradycardic or hypotensive, because it's on the supply side. So, most likely, the BP's already been met for a contraindication. I don't need to worry. Like, if you were sitting there going, hey, I got inferior elevation and a blood pressure 80/50, I'm assuming that's a right side. And I know I can't get nitro. But if they're 160/80 and undimmed, I can still give nitro. Whether it says 2-3 AVF. That's why inferior MI is not a contraindication to nitroglycerin.
So you said right-sided, that's when you'll see bradycardia and hypotension.
I'm saying either or, because I think your RCA, I think he supplies 80% of your blood flow to your SA node. So I had an inferior MI with a 3rd-degree heart block. Remember I told you gotta check the plumbing first before you do the electrical? They took him back to the cath lab. He was having an infarct to the RCA. They fixed it, rhythm returned back to normal. There's nothing wrong with the electrical system. It was a lack of blood flow to the electrical system. It wasn't a short circuit in the electrical system. Does that make sense? All right. So 2-3 AVF, look here. Look at this. 1 looks across the lateral side. 1 AVL, where 1 and 3 come together, that's where you get atrioventricular lateral. It's looking down at the left side. B5 and B6 are looking at the lateral side of the heart. Now, what are they looking at? Most likely, circumflex and LAD. B3 and B4 are right on top of the LAD. So B4 and these little unipolar leads, they're just looking directly right on top of what they're on. So that's why you have good placement of your leads. But you look at it, 3 and 4 are definitely LAD. 5 and 6, I'd say 5 can be a mixture of both, and then 6 could be more circumflex. But you can still be looking at a little portion of the LAD. Does that kind of make sense? It's just cameras. That's all you're doing is manipulate. So like if you look at B3 and B4, and you see ST depression, that could be ischemia, or it could be a reciprocal look. What is reciprocal look? It's the exact opposite. Like if you had elevation, you would have depression. So that's why we do a 15 lead, and we move 4, 5, and 6 to the same spots on the back, and we look at the posterior. If we look at the posterior and it shows elevation, we circle B4 through B6, and we say this is a this is a 15. We label as a 15 lead and say, hey, he's having a posterior MI. And that's where the circumflex wraps around to the backside of the ventricle.
What is the one where you either move, is it V3 or V4 when you move to the...
So if you want to look right here, you want to look at the right side, you need V4 over here. And it gets you a better look at the RCA. But if you're looking for 12-lead type questions, 1, 2, I've seen the 1, 2, and 3 of the bipolar leads. The 12-lead questions are pretty easy. The only other one, it says what, it'll show these, and it'll say, actually, what leads would you look at to diagnose a PE in a 12-lead? There's only 2.
2 and 3.
Huh?
2 and 3.
Nope.
1 and 3.
What you're looking for is S1, Q3, T3. You're looking at the S wave and S1, RM1, and you're looking at the Q for a Q wave in 3 and a Q3, T3. Look at the T wave. 10 3. Hey, don't ask me which way they're going or what they're doing. You know how I diagnose PE? I diagnose it through signs and symptoms in history. That's how you diagnose a PE. I'll be honest with you. That is the best way to diagnose PE. And if they ask about it, I say, what leads? It's 1 and 3. And the way they help remember is like S1, Q3, T3. I don't care. Never done it. Don't pay attention to it. I've diagnosed plenty of PEs in the field, and I've done it off history and symptoms. Does that make sense? So 1 and 3, PE. If it helps you remember it that way. PE 1 and 3. Or I have PE first and third period. I don't care. Alright? But 1 and 3 is for PE, the leads and everything like that. You're talking about which artery they're looking at? Is that in your pocket prep or is that on National Registry?
I think I saw it on National Registry.
Okay. So the way I look at it too is, remember V3 and V4 LED. 5 and 6 can be an LED circumflex combo. But if you just know where they're at, that's what you're looking at. V1 and 2 are looking at the septal wall.
So B1 to B4 will be LAD,
They're going to have LED in it.
and then B5 and B6 will be left circumflex.
5 and 6 would have, 5 and 6 could be a little LED and circumflex.
1 to 3 in ABS RCA.
1 through 3,
No, 2, 3 in ABF.
2 3 AVF looks at the inferior part. They don't look at a specific, it could be LED or RCA.
Okay.
Can't differentiate.
Would it be right circumflex or left circumflex?
Be
Just
left circumflex. The RCA is the right coronary artery. If he goes around to the back, it's the marginal, something marginal artery or something like that.
Is that what the OM is?
Left, oh, LM.
Yeah. Yeah.
That's left main. That's what feeds your left circumflex.
Okay.
It's real small at the top,
So
and
that's
that's your
what, like
feeder.
Sally.
That
Okay,
feeds
yeah.
LAD and
Remember
circumflex.
B1 through B4. So
If you want to think about it,
I just have to.
it's 35, and it feeds
More.
East 20 and West
I was
20.
just going over this
You know what I mean? Like, sublet
Yesterday.
splits apart like that.
Okay.
during the week. Doing the test, I wrote all this.
Alright,
But he gives you.
just for kids, I'm gonna draw some EKG stuff with you before we do cardiac arrest.
Lies.
I want you to tell me what it is.
So basically,
Alright.
stuff that you.
We already did Delta Wave,
Science
right?
system.
Yes, sir.
Yeah.
Florida upstroke.
Okay.
Alright.
Yes.
What if you saw this? That's your J wave or Osborne wave. When would you expect to see that on a patient in the middle of summer?
It's hypothermia.
It's hypothermia. So if you have a hypothermia scenario, be thinking J wave or Osborne wave if they show you the EKG. But that's what you're looking for, that big swoop. All right?
Hypocalcemia?
Heart blocks, tertiary heart blocks on this side. It's all right. I'll show you. You're on it?
It's a prolonged QT in there.
Prolonged QT. What would you look? Females? Zofran use? Levopran use. Prolonged QT. Here is your PR interval. That's a pressure degree block.
Mm-hmm.
All right.
Hyperkalemia?
There you go. Acute. Big T waves. What's the exact opposite of hypercapnia?
Hypo.
Broad, flat T waves. That's hypoK.
Dog, he rose
Huh?
in that dog, he rose to classes.
Yeah, it almost looks like a, no, yeah. They cut the tree off at the base, but I was gonna say like, almost like an entitled that doesn't rise and just runs. Alright,
That's your,
interesting. It's an SD segment elevated. Whereas this is hyper K, but you see the ST segment is good.
Yeah.
That's your ST elevation in mind.
the J part, right?
Whereas this would be sorry. That's your ST depression.
Yep.
ST depression is a sign of ischemia. What's another sign of ischemia? Here's another sign of ischemia.
Okay, P waves. T waves.
Inverted T wave.
Q wave.
They'll call it a pathological Q wave. So when they say pathological Q wave, sorry, so a STEMI can be injury or death.
Mm-hmm.
ST depression, T wave inversion. Those are signs of ischemia. This is a pathological Q wave.
Previous.
This is current death or previous death. How you know it is the Q wave is greater than 1/3 the height of QRS. So if it's greater than 1/3 the height of the whole QRS, then that means active death or previous death. Let's see here. So you do a 12 lead. You see that V1 through V3. The QRSs are running into each other.
Oh, it's,
No. No electrolyte stuff.
Is it a voltage problem?
It's a voltage problem.
Yeah,
Dude.
it's purple.
No.
No, it's, I know what it is, it's, left or right. Left or right, I can't remember.
Water flow?
It's purple.
I'll give you the initials.
Bundle branch block.
LVH.
Yes.
Left ventricular hypertrophy.
Hypertrophy.
Number one cause is untreated hypertension. Think about it. What is your systolic? It's the pressure disorder when the ventricles contract, right? And diastolic is the relaxation. If you're pumping against high pressure all the time because you haven't treated your hypertension, what's going to happen if I go to the gym and I lift heavy weights all the time? What's going to happen to these muscles?
Hypertrophy.
They're going to thicken up, right? You're going to get hypertrophy. You're going to break down, and then the muscle's going to come back thicker. What happens to the left ventricle is it's working against that high pressure, and your stroke volume is like this. Well, as that muscle wall thickens, your stroke volume goes to like that. It's the exact same as heart failure. LVH can cause heart failure. You with me on that? So it thickens up the muscle wall, and that's why you see it. The reason, all right, what stuff you see on EKG? All right, tell me, all right, tell me why it does that. Why do you see ST elevation? If you're to look at a heart attack, and let's say you're having a blockage right here. As it's reading that message over time, right? What happens when you run into a roadblock? And they send you on a detour, right? You got to go around to read that message. It's the same thing. You run into a roadblock, and usually this is your baseline. You run into a roadblock, and hey, you got to take that detour around because there's a blockage. That's why you see ST elevation. It's going around the detour, around the damaged area, and give you a reading. That's why we can use that to predict if that's in your mind. All right? Here, the muscle wall is so thick, we have to use more voltage to get through there. Think about it as like running into some mud. You gotta like kick into four-wheel drive, and you really have to push to get through there and kick up some mud. But to get that reading, we have to go through that thick muscle wall to get that reading because it's just really hard. We have to use more voltage. Does that make sense? All right. Any other EKG stuff? Are you good with heart blocks? Oh, left and right bundle branch. Let's do that real quick. All right, so where do you look to diagnose left and right bundle branch block? B1. Always look at B1. So, first visual sign you're going to see is bunny ears. All right. Usually it's going to be wide. All right. Is that a left or right bundle branch block?
Right.
So what we do is go backwards from the T wave in B1. If it's a negative deflection, use your steering wheel. If it's a negative deflection, which this is a deflection down, it's going to be a left bundle branch block. Left bundle branch blocks are treated just like stents. Because we don't know if they're new like that. So wide, bunny ears, greater than 0.12, and then we go there and say, hey, it's a new left bundle branch block. Why are we worried about left bundle branch? Why do left bundle branch blocks get more attention than the right bundle branch block? What's more important, left ventricle or right ventricle? That's why. That's why they treat it like a stent. Yes. Left side is the favorite child. Right side is the stepchild. I'm telling you. Everything looks at the left.
Do you look at the right? What makes you look at the right? So V1 or?
Yeah, you still look at V1. So I'll have to draw it in reverse to do a right bundle branch block.
How my friend Patrick taught me is that if you can't remember the blinker thing, you won't remember names. Like William is left, Marlon is right.
So this one, our first deflection off the baseline is what? Up. So that is a right bundle branch block. Right bundle branch blocks, we don't give a shit about it. New or old, we don't care. Left bundle branch block, why do we give a shit about that? Where are the bundle branches?
Mm-hmm.
They're Purkinje fibers. And where the Purkinje fibers run through?
That is enough.
Especially the left ventricle. So this is why we care about a left bundle branch block. Why is there a delay in the message? It's like ST elevation in the bundle branch in the Purkinje fibers. Why? As it was, if you're looking at the message, here, comes there good, then it comes there, and it's like, oh, I had to go around to go like that. Why did it have to go around? Maybe there's a big ass injury right there. That's why we care about left bundle branch blocks. Remember, left ventricle, favorite child. Right ventricle, stepchild. That's why we pay so much attention to the left ventricle. All right. Now, what if we give this? What is that? You see the P wave?
No.
No. Well, let's say the dumb kids. Pretend that's wide. There's nothing else. It's PVC. Sorry, I was just trying to draw PVC. So if I could just draw up here, we'll go.
Oh, yeah, okay.
Is that easier?
Yeah.
All right. So you got a PVC. All right. We're gonna go into the whole. What's the football player's name? No, Commissioner Recordis. DeMar Hamlin with the Buffalo Bills. Okay, here's the danger in PVCs. You have these two areas. You got your absolute refractory period. This is your absolute refractory period. And this is your relative refractory period. All right? In our absolute refractory period, we do not want to receive an outside stimulus. Like you have PVCs that come in before, PVCs, PACs, PJCs. You have premature beats that come before the rhythm gets through resetting, right? We don't want anything to hit during that absolute refractory period. Because if it hits at the right part during that little area, it could send them off into a ventricular arrhythmia, VTAC or VFib. All right? This is where PVCs are dangerous. So if you have PVCs, let's say they're throwing one every 10 beats. All right? And they look all the same. So when they look all the same, what do we call that? If you have PVCs, say you're throwing 6 a minute.
Monomorphic.
Monomorphic. What does monomorphic mean?
Same shape.
But what is it
Coming from the same site.
coming from the same pissed off part of the heart? All right. How does the heart let you know it's pissed off? It throws PVCs. All right. You got one area that's pissed off. It's like the one child that's acting up in the classroom, and it's like, hey, he's pissed off. He's letting you know it. He's acting out. That's your PVC. If you have two children that are pissed off in the same classroom, how are they going to let you know? They're going to act up. You're going to get two different looking PVCs, right? So that lets you know you got two areas of the heart that are pissed off. What would make these children calm down? What is the number one treatment for PVCs? Oxygen. Give them a little bit of oxygen. You see PVCs, you give them oxygen. You see runs of VTAC, you see couple of PVCs or two PVCs together. If you got bigeminal, it means what? Every other beat. If you have trigeminal, one every third beat. Quadriminal, one every fourth beat. If you ever run a VTAC, that kid's really getting pissed off. Give them high flow oxygen right off the bat. Calm their ass down. Number one treatment for PVCs. But the reason why PVCs are so dangerous is because we don't know when they're going to act up, but we don't want them acting up right here. Because if it hits during that part, it can send them right to VTAC or VFib. The whole class can be aggravated. You know what I mean? It's like that one bad egg that can disrupt the whole bunch. Remember we lived to de-escalate, not escalate? It could get the whole classroom pissed off. And then it's out of control and I can't control it. All right? So we don't want it right here. Why? This is why we do sync cardioversion.
Yep.
When we do sync cardioversion, we're delivering energy, but we don't want to deliver it during this part. So what it does is it blocks us from hitting during this absolute refractory period.
Mm-hmm.
Because if we hit it, a defibrillation, it just hits as soon as we do it. But a cardioversion will hold it. That's why you have to hold the button down to do it. Hits it, I mean, less than that. But it holds it, doesn't let it hit during that part. It says, hey, nothing can happen in this area. That's why we sync cardioversion. All right? Now, relative refractory, we can start receiving external signals, and it's not going to be a big deal. But if you're throwing more than 6 to 10 PVCs in a minute, now we can, if we give, first thing we do is oxygen, but if we're throwing more than 10 a minute, we can start treating with medication. You can actually start treating that like VTAC. So how do we suppress those PVCs? Medical, or pharmacologically? No. Lidocaine be a good one, or any other one. We need a sodium or what? Potassium channel blocker to suppress it. So this is where you could give amiodarone 150 over 10 minutes. So PVC is greater than 10 minutes, treat it like VTAC with a pulse. That make sense? We start first with oxygenation. Give them oxygen. I've seen multiple PVCs cleared up with just put them on a non-rebreather. Always start least invasive to most invasive. Give them the non-rebreather, and then we can treat it like VTAC with a pulse. Stable VTAC with a pulse. All right? But that is the reason. So what happened to Mark Hamlin? He received it wasn't much of a tackle. He just received that energy directed there at that specific point. It's so rare. That's why I have a name for it, commotio cordis. But that is, so how they'll run it on a test, they could use a football deal now that it's happened there, but it's sudden death caused by a direct blow to the chest. I've been hit with a 95 right here in the chest. On my left side, had the imprint of a baseball, and after learning about this during school, this was when I was playing baseball, I go, holy cow, how did I not go into
You didn't get in the right.
It didn't hit the right spot. If he would have hit a millisecond before or after, I could have gone into cardiac arrest. You know what I mean? So that is why commotio cordis happens. That is why we synchronize cardioversion. So if you're asking the danger is hitting during that absolutely nothing needs to come during this period. Absolutely refractory period. We can have some in the relative refractory period, like, hey, we can have those all day long. But we don't want it, and that's the danger of throwing multiple PVCs. That's why we treat PVCs when we see them. Treat them with oxygen. All right. Does anybody have trouble with blocks? All right. How do you know it's a 3rd-degree block?
There's no P's in QRS.
So what are the P waves going to be running at?
Whatever they want to.
Their own rate, and the ventricles will be their own.
60 to 100, 20 to 40.
Mm-hmm.
Think about it. Ventricles function at 20 to 40. SA now goes 60 to 100. So your P waves are going to march out at 60 to 100, and your Q waves, QRSs, are going to be longer. That's why you have more. That's why you have a mixed ratio. All right. How do you know the difference between a 2nd degree type 1 and a 2nd degree type 2? If I'd say pick one thing,
It'll draw
see, to me, the PR interval is always the same.
Yeah.
More P's and Q's, and the PR interval is always the same.
It's
So
just,
more P's and
it's
Q's,
just
listen.
your longer P waves.
Yeah, you drop a beat with the Wikibot,
Yeah.
type 1. But to me, the PR interval stays the same. That's the one I'm looking at. That's a consistent. You know what I mean? I'm not waiting for longer. I just go, I can look at one sample, 2 samples, and I go, hey, is the PR interval the same? Okay.
Yeah,
Then it's a fix. If not, it's a winky bob.
yeah.
I work my way from 3rd degree back. But I sit there and look at it, I go, is there more P's and Q's? And I go, okay, and I can visually see if the P to P's were marching out and the QRS's were marching out. Hey, take your time, measure it with your sheet, with the computer, so you make sure you don't miss this one. And go, okay, this is a 3rd degree. And then after that, I just look at the PR interval. If it's not a 3rd degree, I just look at the PR interval and I go, okay, the PR interval's fixed? No. It's a winky box? Yes, it's fixed. All right. Junctional waves. Huh?
40 to 60.
All right. I want you to think about it like this. If the message comes here, SA node down to AV node down here, if it comes like it's normal, you see an upright P wave, right? This is the primary middle. So the message is got to go up, then down. That's why you get inverted P wave. It's coming from the bottom, right? Or if it depolarizes at the same time, it's narrower, but it's hidden in the P wave, hidden in the QRS. That's a shitty drawing, I know. But it's hidden in the QRS. That's why you just got to be looking for it. That'll be like this. But it's just the way the electricity's traveling. All right? All right? All right. Cardiac. We need 5 here. Take 5 now. Go through it and then just give it, just give it your best effort. But I will not tell you like, hey, this test, you're gonna feel like you got kicked in the nuts or the face or wherever you get kicked and it hurts the most. All right? But also don't go through and figure out stuff, like if you're trying to pass on help to other students, go through and give them subjects. Don't give them specifics. Like, hey, I got a snake bite. Or hey, I had a, SVT unstable. Just do that. I had an SVT stable. I had this. And help them out that way. Just generalize it for them. Don't have to be specific. Just say, hey, I got this, 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 and this. And it'll help them prepare, give them a little more confidence. And then you go through, take it, and then just wait it out to see what you got. But again, don't sit there and say, hey, like you're gonna get crap you don't understand, and it's okay. Because remember, 20 of them are pilots, and the questions are supposed to get harder as you're doing better. So if they're getting harder, it's a good sign. Now, I used to tell people that you see the same kind of answer, see the same kind of question, and you answer it a certain way 2 or 3 times in a row, and you go, okay, I'm still getting this kind of question. I'd say, hey, change your answer. Don't do that. They have totally changed the way they test now. If you get a flail chest and it says, what do you want to do? And you're like, ventilate. 2 questions later, you get another flail chest and it says, what do you want to do? And you go ventilate. And you get another one, triple down on it, because that's the right answer. Don't change your answers. The test has changed, but use that common sense. Use the stuff we've taught you, like that. But just go in confident. And we were talking about ways to release stress before you go in, like sauna. Get rid of the stress hormone. You can get rid of cortisol through sweating, peeing, or crying. Have yourself a real good cry. Hey, hit that sauna. Get a workout in. Do all those kind of. Don't do a workout to exactly exhaust you. You don't want to be completely exhausted, but yeah, a workout would be a great idea. It's a way to release stress and go in confident. All right, hit the what do you call it, the treadmill, mouse wheel, hamster wheel. You know what I mean? Hit the bike. Hit something just to get a little sweat going and get some of that cortisol out. Hit a sauna, or drink a lot of water, pee it out. But I will say this. Don't drink so much water you're going to have to get up and go pee in the exam. because you know you have to scan in. Have
Yeah.
you ever had to go to the bathroom during that test?
Yeah.
You got to palm scan out. It's like it takes 10 minutes off your test time. Yeah.
Not gonna lie,
Well,
if you
for
go
mine-
to Hillsborough and test there, they don't do any of that.
Oh yeah. It's
I'm so serious. It's
Really?
it's a little man in an office, he doesn't care what you do.
All right. If you go to Dallas, South Dallas, at Wells Fargo, it's by the Wells Fargo baby.
Mhm.
They will pat you down.
They do.
Yeah.
I've been there.
A lot of Hillsborough. Pretty
Yeah.
good.
They will pat down and if they're turning across inside out, the hair's up, I think the hair.
Yes.
Take your glasses off.
That's how mine-
If you want to feel like you've
EMT
committed a crime,
was-
go to the one off the 67th in the Wells Fargo
And you have
building.
to fight God to show you on if you have one.
If you go to the Arlington one over by the Parks Mall, they are straight running bitches. Just telling you. Now, if you go to Waco in the Wells Fargo building, they're old ladies and they're super nice. They're retired teachers and they're awesome.
Mm-hmm.
A lot of retired teachers run this place.
Yeah. Even in the college, they don't like, it's an old lady too. It's like, just
Yeah.
put all your stuff in there, lock it, and we take you in. It's like, okay.
Yeah.
Hillsborough is
Yeah.
a little more relaxing.
I've had 2 tests on a Monday and 1 on a Tuesday.
Mhm.
I don't think Monday's the right day either. So.
Hey, here's another little deal. Try to pick a place that you, like, if the last time you passed was your EMT, and you like testing there, go test there. It's a mental deal. It's a psych deal.
Not
Go to
driving.
a place that's familiar. You know what I mean? I always like playing at certain baseball fields. Like, I walked in and I just felt confident because I could see the ball better, whatever. I knew I was gonna go off that day.
I'm not driving to Austin.
Uh-huh.
I'm not driving to Austin.
Oh.
Not for that.
It's not easy to get the same place I've been 3 times. Medic, so.
Really? Change your place.
Yeah.
I went to Shreveport, so I could go to the casino after.
Smart. Also, why don't I have a drink after? After every promotional test and every national register test, I literally go somewhere and just have a beer. And it's just like, just relax yourself a little bit. Don't have like 4 or 5. You still gotta drive. Once you go home, then you can have 4 or 5.
I have another question.
Go for it.
With how many national registry tests you've done, what's your average like cutoff question?
80 every time. I kick its ass and I love doing it. It's like one of my favorite things to do. I literally can't wait for that. I put in to go do national registry test questions every year, and I'm not gonna do it. I can't wait. I'm gonna throw, because you're supposed to bring 25 questions and then polish them and everything. I'm gonna bring 25 of mine, and I'm gonna bring 25 of their shit questions and throw them back in their face. I can't stand national registry. I know many dudes that work for him. Paul Rosenberger, he was my instructor. He's one of the head dudes there. And every time I call him, I was like, I can't believe you work for such a shit company. And he just goes, whatever. And I was like, your place is equal. Alright, let's do, I'm trying to think if any other, is there any, alright. I feel like I still have to, I can do OP, I know I can do OP. I still like for some more cardiac deals, but I try not to go off on.
Tangent.
Alright, so are we good with the signs and symptoms of acute myocardial infarction? Like a typical MI? Chest pain,
Pretty
abdominal
easy.
pain, left jaw pain? Okay. Alright, what if you had a silent MI? Who is at risk for a silent MI?
Okay.
Geriatric.
Older people, females, especially elderly females, and diabetics, because they don't perceive pain the same. So a silent MI will be everything but the classic chest pain. Usually theirs is abdominal pain, nausea, vomiting, shortness of breath, like that. So, hey, here's your keys. Everybody over 65 gets 12. Unless you're dealing with like major trauma or something like that. But usually it gets a medical patient, they get, I don't care if they're just nauseous and vomiting. Like my mom is she's an 80-year-old diabetic. Guess what? She's gonna get 12 bleed every time.
It's in our protocols. Every time it's abdominal pain or nausea, vomiting.
It's just something to watch out for. I'm not saying you're gonna get a little salad on, you get it. All right, now, what is, God dang, is the chest pain relieved by stress or relieved by rest?
Angina.
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 Angina. Or angina, I don't care. Angina. Chest pain relieved by rest, or O2, or nitro. If one of those takes it away, you're good. If those three don't take it away, then it's called unstable angina. I'm not saying anything anybody doesn't know already, right?
No.
All right. So angina is just chest pain. It could be a spasm, something like that. You take a nitro, it goes away, it's angina. And STEMI is diagnosed by an EKG. ST elevation MI. That's what STEMI stands for. All right. And STEMI is where you get the signs and symptoms, but you don't get the elevation. Do you know what blood work we take them in to go get? Troponin. What is troponin?
The stress.
Heart, muscle
No.
enzyme.
It's a hormone.
It's an enzyme produced
By death,
by muscle death. And it could be any muscle death. But troponin is specific to cardiac muscle death.
Which one's the stress one with the heart?
I don't know what you're asking.
Well, no, which one are we, because we thought like troponin was.
Troponin is a it's a byproduct of cardiac muscle death. CK would be any muscle death. But troponin levels go up with muscle death, especially cardiac muscle death, and they have to do it every 4 hours. So if you have a positive STEMI and a positive troponin, you go to cath lab. If you have a regular EKG and an elevated troponin, they will run it again in 4 hours. That makes sense? But if you have both together, or sometimes a STEMI is good enough to take them back to the cath lab, but if you only have troponin, they're going to run it again in 4 hours. Let's see here. Angina, all right. We did, holy shit, I realized we never did did we never do emphysema and all that?
The birthday, yes. Yeah, we do.
We did? Yeah. I wrote out pneumonia and all that?
Mm-hmm.
I did, for sure?
Yeah.
So you know,
We did croup, we did
Yeah,
hepatitis.
pneumonia, fever.
I don't think we did
I wrote it out.
emphysema though.
The differentiator. Alright. Alright. PE. Let's do real quick for you, prior to this. PE. Play.
I don't think we did emphysema.
Material. What's the material? What one? It's a clot on the arterial side, the blockage. No, it's not DVT, it's not on the venous side. It's arterial.
DAT? Peripheral arterial disease?
No, it's arterial. It's a clot that blocks off. It's almost like a tourniquet. Same signs and symptoms.
It's like different
Aneurysm?
pulses on each different.
No, it's like if you had an arterial block in your right arm, and it acts like a tourniquet. Everything below it, pallor, the 5 Ps, but it's called arterial. Oh my God. Arterial.
You're talking about arteriosclerosis?
No, arterial occlusion. Sorry, arterial occlusion. All right, we'll do CHF and heart rate. All right, so DVT, deep vein thrombosis. Thrombosis is when the clot forms and stays. When it becomes mobile, it becomes an emboli, right? These are going to have different signs and symptoms, same history precursors. So, DVT will be leg pain, a difference in temperature, swelling. And the difference in temperature will be warm. Swelling, and they may call it dorsal pain. So like when you make, where does this usually happen, DVT?
The legs.
It's usually in the calf, maybe in the upper leg, but they'll say dorsal flexion pain. So like, think about it, when you flex your calves, that's dorsal flexion. So when you flex, it hurts. And so one calf is going to be bigger than the other. It's going to be warm to the touch. Because remember, veins have backflow pumps in them, but like to push it up, it's going to be stuck right here. So when it's stuck right here, blood is warm. So it's going to be warm to the touch. So it's going to be swollen, warm to the touch.
Color difference?
Huh?
Would there be a color difference?
No color difference. Because it's not on the arterial side.
Would it be gradual or acute?
Probably gradual. The acute side is when it goes mobile. So when it goes mobile, it comes up through here, goes to the right atrium, down through the tricuspid, down through the pulmonic, and it lodges in the small vessels. So just like whenever you have a blockage in your coronary arteries, you have a heart attack. If you have a blockage in your cerebral arteries, you get a stroke or a brain attack. This is like a lung attack for your pulmonary circulation. All right? Now, this will be acute shortness of breath and chest pain. I just want you to notice, this is going to be clear breath sounds. There's nothing going on the, it's all on the what? Perfusion side. Nothing on the ventilation side. Nothing inside the alveoli or anything like that. Here's where they come together. This is where you got to go to the history. What's going to be the history?
Surgery.
Yes, that's a big one. Remember, if you're dealing with somebody who just had recent surgery, you got to remember some stuff is surgery. Like, not just like major surgery. If you had something implanted, a pacemaker, that's a surgery. If you had some kind of surgical implant for like a deal for cancer medicine, chemo and stuff like that, that's a surgery. Anytime where you break the skin and you're implanting something or fixing something on the inside, that's surgery. So that's a recent history of surgery.
Long car rides.
Yep, long travel, whether it's plane or car. What else?
And recently stopping here.
Blood thinners? No. That would actually help.
Recently stopping.
Hey,
Oh,
Oh,
you're like recently stopping.
yeah, could be.
That's not recently.
No, not one of the big history deals.
Can AFib get it?
Huh?
Or would that just be more towards?
AFib is risk for stroke.
You go
This is going to
pregnant?
be pumped out to the ventricle, up to the aortic arch, up to the brain.
Pregnancy?
Pregnancy.
I was trying to say it.
What else with these creatures? Can you do? Women? Yep, periods. No. All right. What's the medical term for a condom? It's something to prevent pregnancy. What's that name?
Oh,
Oral contraceptive.
God.
Y'all
control.
take
Birth control.
oral contraceptive. So oral contraceptive use. I just want the guys to be familiar with that terminology. If they say oral contraceptive, it just means a pill. It's something you take orally to prevent pregnancy. Contraceptive is prevent pregnancy. Oral is by mouth. So if they take the pill, they're not going to say the pill. They're going to say oral contraceptive. What else?
Would it be like sedentary?
There you go. Sedentary. That could mean nursing home,
Oh.
hospital,
moving.
or that could mean just a lot of non-movement. They're at risk. Sedentary lifestyle, because what happens to blood when you sit for a long time? It pulls, and when it pulls, it coagulates. Coagulation leads to clotting.
So why in pregnancy? Is it just sitting down a lot? Or?
Could be more of the pregnancy. Usually they're more at risk pregnancy when they have to do bed rest or something like that. So you get that sedentary lifestyle. But like if you ran on, or if you're delivering a baby, then a scenario would be like you deliver a baby and then mom starts complaining chest pain and then she goes into cardiac arrest. What happened? She just threw a PE. Now, it could be a blood PE or it could be an amniotic fluid embolus got into the bloodstream. I can give you an example of that. 22-year-old chest pain. Healthy looking, doesn't look like a drug addict, doesn't look like she's led a hard life. She's laying in bed. It's like one of my first calls. And I'm sitting there looking at her. She's got the covers on. She's 22. She's fit. Like, I'm not seeing anything medically. But, you know what I mean? Like, people you expect to be like, hey, there's something medical wrong with them. All right? Nothing's meeting the criteria. Do the 12 lead, it's clear. And I'm just going. I was like, look, I can't figure it out. I don't know why you're having chest pain. Breast sounds are clear. EKG looks great. All this other stuff. And I'm just like, you know what? But it's not normal. We should probably bring you up to the hospital. We take the covers off. She has an external fixator on her leg. You know what that is? Like when you break a bone and you have the like erector set on the outside where they have to pin it.
Mm-hmm.
Instead of being a cast, it's like a
Like a cage?
Like a cage.
yeah, it's like a cage for your leg. And I said, and I go, wait a minute, what's that? And she goes, I just came from Walter Reed Hospital. I was over in Iraq. We had a Humvee, IEDs, explosions. Humvee, I had a fractured tib fib or whatever. They did the deal. I just had the surgery 2 days ago. I was like, light bulb. And I just go, I write PE on my glove and show it to my FTO. He goes, you can say it out loud. And I go, I think she's having a PE. He said, I do too. It's like, okay, let's go. She's having a PE. Not a big one, but she's having a PE. Long car travel. Long plane travel. We're dealing with a mom on the north side of McKinney. The mom doesn't speak English. She's Russian. All I've got is sudden onset of chest pain, shortness of breath. I'm like, okay. She's older. That meets the need for, doing a 12 lead. I'm like, hey, let's do a 12 lead. Can't figure it out and everything like that. And she's living with them now. And then, like, somewhere in the conversation, I pick up on a little tidbit. I go, wait a minute. I go, has she been here for a long time? It's like, no, she just got here yesterday. I said, how long does that travel from Russia? 23-hour plane ride. I go, okay, we're dealing with P. Let's go. You know what I mean? I just need that little bit of, I need that history. Pregnancy, oral contraceptive use. So females are always at risk, especially during childbirth years. Because I don't know if they're always asking if they're taking the pill. Sedentary lifestyle, old people are always at risk. Nursing homes, hospitals. Hospitals are trying to prevent two things. All right? Has anybody had a hospital stay or work in a hospital? All right? Did y'all do anything on the floor in clinicals or just
ICU.
After surgeries, they make them walk around.
All right. While they're in hospital beds, they get a daily Lovenox shot. It's a shot in the belly. It's a blood thinner. The reason why? Prevent clots. That's what I was saying. People with clots, they take blood thinners, but I didn't know you were asking the other thing.
Yeah, I just had a
That makes sense to me. It
I had a
does.
patient recently that got pissed off at his doctor, stopped it, and had a big hole.
To me, it makes sense. So recent stoppage of blood thinner use could put you at risk. But sedentary lifestyle, yeah. Just by walking every day, that's why you want to get old people up and walking post-surgery. It pumps like 30% of your blood back to your heart. Just flexing those muscles. All right? But anything that puts them at risk, puts them in here. So this is acute shortness of breath, chest pain, clear breath sound. This will be the leg pain, dorsal flexion pain. They'll be dead on what they're doing. All right. AAA, abdominal aortic aneurysm. What are the signs and symptoms going to be?
Alternating.
No, no chest pain.
Back pain, I mean, it goes through.
The shoulder blades.
No. You're on the next one.
Oh, I'm sorry.
Abdominal pain
It goes to the back.
that radiates to your back. Put that down. Think of where the aorta lives, right there in the middle, and think about it from the side plane view. It lives right in the middle. I don't know if it's the abdominal pain that goes to the back or if you're having both at the same time with the same pain receptors. All right. The other one is going to be, the other big one is pulsating mass. You palpate, you feel a pulse, you press in, you feel a pulse, AAA. Now, you will get differentiating pedal pulses. So if you think of blood flow, let's say you get down here and it splits down to the femoral arteries. All right? If you have this little guy, and you get diverted blood flow in there, one side's going to get full blood flow, the other one's going to get diverted. So if you feel pulses, pedal pulses at the end, it's because we don't take blood pressures in legs. So that's why you get differentiating pedal pulses. But the key thing will be abdominal pain that radiates to the back, and they'll probably give you pulsating mass.
What about alternating, like, blood pressures, two different?
So we don't take blood pressure in legs. That's going to be for the next one.
Oh, I thought we were on that one.
So the next one is called, all right, so here's where it happens, at the aortic arch. I'm used to calling it a thoracic aortic arch aneurysm. What they're going to call it on your test is just an aortic aneurysm. The AAA, they name it by where it is, the abdominal. An aortic aneurysm, which is the AA, here's what happens. You get full blood flow to the right, you get diverted blood flow to the left. So you'll get a normal blood pressure on the right and a lower blood pressure on the left. So this is the one that is chest pain, that radiates to your back. This is the ripping and tearing between your shoulder blades. You get different blood pressures in each arm. And I think that's about it. I had a lady with this.
Wait, that's for the,
This is for AA, aortic aneurysm.
so what did you say?
Huh?
What was it again?
Chest pain radiating to the back. Ripping and tearing between shoulder blades. And this is the one that gives you different BPs in each arm. Alright. We had a lady with this, diagnosed with it, and I literally used her as a test subject. And I said, where's your pain at? She goes, here. I said, does it go anywhere? She goes to my back. And I said, what's it feel like back there? She goes, it feels like somebody is ripping my back apart. And I go, okay, it's ripping and tearing. And I was like, and I did blood pressures on both arms, and her right one was regular, her left one was lower. And I was like, and my buddy knew what I was doing. He goes, stop, dude. He's like, we all know she has it. Like, she told us she has it. I was like, okay, I just want to see if it's going by the book or not. All right. Arterial occlusion. I've only had this once. It's when you get typically you don't get blood clots on the arterial side a lot in the body. But this is a clot on the arterial side that causes lack of blood flow to the extremity. It's going to be everything you would expect it. It's the 5 Ps from putting a tourniquet on. Just think about it. What's it blocking? The arterial side. So I had a guy with the brachial artery one. He calls, he's 28 years old, he calls for arm pain. And I'm like, really, dude? Freaking arm pain? Like, you think it's like a bullshit call. Hey, this is why you touch everybody. I go down there and I'm like, feel the pulse. I'm like, shit. It's like 97 degrees outside, his arm's ice cold. Now I look at his arm, I was like, he's wearing a long sleeve. And I go, oh, dude, you got no color. And I go, how long has this been going on? He's like, a couple hours. And I go, and I was like, I didn't even realize I can't feel a pulse. And I go, hey, we need to go. Like, let's go. It's everything. So the 5 P's of this. Does it hurt when you put on a tourniquet?
Yeah.
Pain. All you gotta do is think of everything you would feel with a tourniquet on. Pain. What color does your arm turn without blood flow? Pale. So pallor. That's your other P. What happens before you go completely numb? The pins and needles?
Yeah.
The pins and needles is called paresthesia. Parthesia. When you go completely numb, it's called paralysis. And I feel like I'm gonna miss the last P. Pain, pallor, paresthesia, paralysis. Oh, pulselessness. You won't feel a pulse. So it's everything you would have for putting on a tourniquet. That's how the easiest way I have to remember it. Very rare, but if you get it, it's a clot on the arterial side. Okay. CHF. We'll walk you through it. Because it's good because I got my RAS system up and everything like that. All right. CHF. You have an MI, and let's say you lose 30% of your function of your left ventricle. Does that stop so you got the supply side and this is your distribution, right?
Mm-hmm.
Does that affect anything on the supply side? The factory workers are still working, right?
Yeah.
And they're still bringing the same amount of boxes to the distribution. You're down 10 trucks. You know what I mean? It's like Amazon. You're down 10 trucks. So what happens is you're going to have a backup. And as you have the backup, it's going to back up into your pulmonary vein, and you're going to get here. This is your blood flow, and all the other stuff. And this is what happens to CHF. All right? So you're going to start feeling like you're drowning because you got the rattles and crackles, right? So you're going to have chest pain, maybe. Shortness of breath, for sure, shortness of breath. And then you're going to get some rails in here inside the pulmonary, inside the alveoli. All right? Now you have blood or plasma inside the alveoli. It mixes with air. What are you going to see externally? Pink frothy sputum. Pink frothy sputum. So pink frothy sputum. Heart rate, respiratory rate, and BP are all going to be up. An example of CHF, acute exacerbation of CHF, an example of vital signs would be like this.
You said heart rate, blood pressure, and what?
Respiratory rate. That's what it's going to look like. They're going to be in volume and pressure overload. Okay, so you got all this building up. Another deal is these patients don't want to lay down. And as this builds up and gets worse, they will want to sit straight up when they're sitting up. So we ask them how many pillows they sleep on. If they're sleeping on 3 to 4 pillows, that means they're pretty much sleeping straight up. That means they got a lot of fluid in their lungs. All right? So we call this paroxysmal nocturnal PND. They don't want to sleep laying flat. Now, if the boxes aren't going out, the distribution side, do you think the kidneys are getting their 30%?
No.
So this system works against CHF. All this other stuff, what happens? Volume and pressure goes up. Do you want your heart, a failing heart, to pump against high pressure? No. So it's going to make it worse. So the first thing we do for this treatment, what's our very first thing? Our airway, right? A and B. What are we going to do? CPAP. We're going to open up those alveoli, and you're going to feel a lot of relief. So First thing we're gonna do is CPAP. What's the next thing we're gonna do?
Nitro.
Nitro. Don't do ANA, because we're not wheezing. Remember, it's not just for shortness of breath, it's specific for wheezing. Alright, wheezing and bronchi. So, we're gonna do nitro. How is nitro gonna help us?
So basically, dilate.
It lowers the blood
Opens
pressure.
everything.
It'll lower the pressure, probably lower the pressure we're pumping against, right? But it will also increase the amount of blood flow to the failing muscle. So it'll reduce the myocardial oxygen demand and help it out, help the failing pump. Alright? Maybe we don't give it more trucks, but maybe we get a truck that can carry more boxes. You know what I mean? Try to help it out. Alright? Then, we have to do one more thing. Well, two more things. But we cannot give them a diuretic until we do something else. We have to shut down the system that's working against us. So how do you shut down that system of medicine? Give them an ACE inhibitor. Give them an ACE inhibitor. So enalapril, IV, captopril, you give that IV. This is why in our medicine here around the Metroplex, unless you get further out, they will just stick with CPAP and nitro.
Yeah.
They will not take it to Lasix. The reason why is called the bucket theory. So, here's your bucket theory. If you give somebody Lasix in this situation, it is going to make them feel better initially. But essentially, in your bucket, you have 5 liters. If you drop it down to a 4-liter tank, right, we get rid of some volume, we let them pee it out, we get rid of some volume. This should make it easier for them, right? It's going to lower the pressure. If we get rid of some volume, it'll take care of a little volume, a low pressure. All right? Only problem is, once the kidneys realize after 15 minutes or 30 minutes that we're peeing out all our volume, and we're reducing that, it's going to realize, hey, this is like shock, and it's going to kick up even worse. So the problem with, back in the day was we were giving them Lasix without shutting this down, and they would end up with like 3-week ICU stays because we were giving them like up to 2 rounds of Lasix. Because it worked great for us, it was shit for them at the hospital. It doesn't work unless you shut down that system. So you can give an ACE inhibitor, enalapril, and then you can follow it up with a diuretic, Lasix. But it's the bucket theory. Every time you keep lowering the amount of fluid in the bucket, the RAS kicks in even harder. Does that make sense? But in the Metroplex, we stick with CPAP and nitro. Further out, they'll do a little more management. Flight medics, they'll do a little more management. All right? Now, heart failure, I say congestive heart failure because that is left-sided is always going to be CHF. Regular heart failure, which is on the supply side, where do you think the fluid's going to back up to?
Legs.
So you're going to get the pedal edema, sacral edema back here, the pitting edema. So you can feel it right back there and push in just like you do the pitting edema. Now these people are going to get short of breath. This is a chronic problem, not an acute issue. CHF is acute. Heart failure is a chronic issue. So they get short of breath because they're dragging around excess fluid around. It's like putting a 2-pound ankle weight on somebody, and then the next day add 2 more pounds. Then the next day add 2 more pounds. They get short of breath because they're dragging around extra weight because they're dragging all that fetal edema around. Does that make sense? Now, believe it or not, treatment for this is fluids. Because it's on the supply side. You get fluids. But that's the main treatment for the heart failure deal. Fluids, give them oxygen if they need it, all that other stuff. But this is a chronic issue. What they'll do is they'll take them in there and diurese them. Like my dad, he had, you know what the number 1 cause of right side heart failure is? Smoke. And it's a natural question. Smokers end up with right side heart failure because they end up with something called cor pulmonale. You know what cor pulmonale is? Is what? It's the thing that causes right side heart failure. So it's pulmonary hypertension. So it's hypertension of the pulmonary circulation. So just like on CHF, we're pumping against high pressures, they're pumping against high lung pressures. So that's why the right side is getting thicker and failing. So cor pulmonale is just pulmonary hypertension. You would expect that to see it in COPD patients. But when you see cor pulmonale, it's just pulmonary hypertension. That's all it is. Expect to see it as well. Like my dad had all the right-sided heart treatment, like medications. He never had, it almost looks like CHF medications, but it was right-sided. But he would take Lasix and everything and get backed up and all that good stuff. I think we're good to move on to cardiac arrest. All right. So cardiac arrest. I could go through this whole explanation, but I'll tell you how the test questions are going to look. You're working at cardiac arrest, and your patient's in this rhythm. They might show it to you, or might say it's B-fib. B-fib or pulses B-tach. And you're working this arrest, and it says you have intubated, you've started an IV, you've done all this other stuff, and you've given epi, and it's time to, you've done a pulse check, you just did a defibrillation, and you restart CPR. It's like, what's your next drill? And if you've already done one epi, then you do an amiodarone. So, I'm trying to do it without writing the whole deal out there, but you need to think of, I can't do it. I'll try to do it small. So, cardiac arrest, I want you to think of two ways: shockable and non-shockable. What are your non-shockables? And? Yeah. Yes. This is your asystole, PEA. This is your V-tib, V-tach without pulse. The way I usually do it is I do it in 2-minute rounds. All right? But, so think of these as your first, second, third, fourth, fifth, and sixth. So each one of these rounds is 2 minutes. Does that make sense? So what are we going to do the very first round? What do we got to concentrate on? Nope.
CPR.
CPR. CPR plus IV. That's the same for, I'll put the little caveat at the top here in a minute. All right, so we do CPR for 2 minutes. We get an IV. What do we do in between rounds on the shockable side?
Yeah.
No.
Airway.
Defib. So our little defib goes in between each round. Defib. 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 So our little defib goes in between each round, just on this side. Now, the caveat to the shockable deal, if we witness them go into VFib, what do we do first? Shock. If you have the pads on them, you shock. If not, you do CPR until you get the pads on, then you shock. But when we say witness, what does that mean to you? We saw them die.
Not someone else.
Not somebody else.
I have seen that.
So if we saw them die, they died right in front of us, we know that the answer is always going to be shock immediately. So,
Exactly what we did.
CPR, there's your round 1. Round 2, now we have an IV. CPR plus epi, 1 milligram, plus ETT, ETT just means advanced airway. It's the same over here. Keep running that out, we run that. Exactly. Alright, apologize. Blood is old. Alright, CPR plus epi. There's your first epi. Entitled, and the same. Alright, now, this side your defib. Alright, now, here's where they start changing. CPR plus amnio. 300. Over here, is CPR only. And honestly, amnio or Lido. I think it's 1.0 to 1.5 milligrams per kilogram. I could write this all out, but here's the big difference. How often do we give epi?
3 to 5 minutes.
Epi, how long are the rounds?
2 minutes.
No, 5 minutes.
You see how it alternates? It's going to do, I'm going to put epi down here, and it's going to be the same across. And then the next one, I'm going to go amnio 150, and I'm going to go Orlido. It goes epi, antiarrhythmic, epi, antiarrhythmic. But there's nothing that says you can't give epi and amnio together. But what they're going to do on this is they're going to say, hey, you just alternate. So it'll ask the test questions like, you just defibrillated, or it just says you just did CPR, patients in a VFib, and you just did 2 minutes of CPR, and it says, what do you do next? You know what I mean? So I'm going to defibrillate. And the only big deal on defibrillation, what does it say on that deal? What's the range? If it's
Got the biphasic.
biphasic or monophasic?
Biphasic's 120 through 200, and then monophasic is 360.
So if it says 360, it's right. If it says 200, it's right. You just got to know it's 120 to 200 or 360. They're not going to give you the biphasic, monophasic. I've never seen them give it to you. They just give you the joules, or it'll say defibrillation. Now, another way to say defibrillation, and this is like one of those smart asses that wrote a test, is asynchronous cardioversion. Asynchronous cardioversion, A means without synchronization, it's just defibrillation. And if I could reach through the test and slap the person who wrote that, I would. But asynchronous cardioversion is the same thing as defibrillation. All you gotta know is when you get done with your 2 minutes and they're a shockable rhythm, what do? Shock 'em. You gotta know where you're at with your drug regimen. If they say you've already given one epi and you know it's at a time when you need to give a drug, and you just defibrillated, start CPR and give amiodarone. Start CPR and give lidocaine. You just gotta know the rhythm of this. I could write it out like this, but it doesn't always happen. As long as you know that, hey, if you know the concepts of it, then you'll have it down. The concepts are, hey, is CPR 2 minutes, and get done. If it's a shocking rhythm, a shock. No longer than 10 seconds off the chest. I don't know if they'll ask that, but how far is the depth of compression? They usually ask this on pediatric. 2 inches. Alright, and then it'll say change compressors every 2 minutes. You're used to that. It's 30 to 2. It's always 30 to 2 unless it's what? Pediatric. Pediatric, we can go 15 to 2. Monophasic. Epi, I would know your epi dose. I mean, of course you know that. Amiodarone, I think you're good with. And then lidocaine, 1 to 1.5, sodium channel blocker. And then 0.5 to 7.5. Intubation or supraglottic. Just know the rhythm of this. Epi, antiarrhythmic. Epi, antiarrhythmic. Because that's what it says right there. Epi, then amiodarone. And it just repeats itself until you run out. Yeah, it's going to be able to start. It usually won't go past about 5 rounds. As long as you know that those concepts, you're good. H's and T's. All right. Most of them we're already fixing. Give me an H. So hypovolemia, we've already fixed that. We're doing fluids, right? IVO, checkbox, it's done. Hypoxia,
CDM.
we're ventilating them. Checkbox, it's done. Hydrogen ion acidosis. This is the one I told you about that's stupid. But it's going to say give them bicarb.
Yep.
Well, the problem with giving bicarb is you're going to make them more acidic. And you can't get rid of it. You have no, you don't have to, you can't make it pee it out because of it. Hyperkalemia. Now, hyperkalemia. You're going to say, hey, I can see that through peak T waves. When does that show up on a systole?
No.
So what do we do? How do we treat hyperkalemia? What do we base it on? So if we see a shunt, or if we know they receive dialysis, then what are we going to do? Go ahead and give them the hyper-K treatment, which is calcium. We can't treat hypokalemia. The reason why we can't treat it because we can't get potassium into it. Hypothermia. Warm them up. 1 round. This is a key deal for hypothermia. 1 round of drugs. 1 round of drugs until we get them above 92. Because that's when they start circulating. All right, your T's, tension IMO, what do? You DART. Tamponade, what do?
Pericarditis.
Yep. Toxins,
Depends on where it is.
give them the antidote. What's your antidote for opiates?
Okay.
You know what's funny is doctors will tell you Narcan will not work when they're dead. But there's even doctors that say that. And I've heard them on podcasts. They go, "Hey man, I would say it doesn't work, but it works sometimes." And it goes, I can't explain it.
I like to throw it in there. Just in
Yeah,
case.
just throw the kitchen sink at them. All right, what if they have beta blocker overdose? What do you give them?
Good.
All right. What if they have what are your other antidotes?
Atropine.
What if they have a TCA overdose? Tricyclic.
Sodium bicarbonate.
Sodium bicarb. If it's a sodium channel blocker, you give the concentrated amount of sodium. So whatever the toxin deals, if you can figure, honestly, PEA, when you're talking about H's and T's, and you can do H's and T's on both sides, hey, if you think there's a cause, you ain't gonna make them any deader. If you have something to work off of, throw it out. If you have an antidote. All right, thrombosis coronary and thrombosis pulmonary. You take them to a hospital with a PCI capability, percutaneous intervention. You take them somewhere with a cath lab. That's it. Now let's do pediatric real quick. All right. So, I always like to put the pediatric and the adult right next to each other so I can see that there's not much different, except the dose, right? All right. Now, for pediatric, citizens get back valve ventilation, detect monitor, shockable rhythm. What are we going to do? Shock. Now, here's the deal with pediatric. Here's how you shock. First round, how many joules per kilogram?
2.
And they love to ask you about this.
0.5.
Who's it? Who what?
That's
two.
what we
Two.
were talking, 4, 6, 8, that's what we could
Well, it's greater than 4. I knew it was 4 to 10, but I like that. 2, 4, 6, 8. That's how we defibrillate. All right. They will ask you a question over this. So, let's say you got that 14-pound kid or 15-pound kid,
It'll make you forget.
or let's say 22. You got a 22-pound kid. We got to convert them to 11 or 10. 10 kilograms. It's going to say you're doing your first shot. Here's how they're going to, you know it's 2 joules per kilogram, right?
Yeah.
You know the next one's 4 joules, right?
Mm-hmm.
That's verbatim how they're going to write it. They're going to anticipate you not converting to kilograms, and they're going to give you 2 joules per pound, and they're going to give you 2 joules per kilogram. Then they're going to give you 4 joules per pound and 4 joules per kilogram. I have missed this question because I overlooked it, and I didn't convert it. So when you get to the joules per kilogram in a pediatric cardiac arrest, slow the fuck down. And you do it. Just remember, Waller said slow the fuck down. This is one of those questions I need to slow down on and make sure I convert it and know it's the first shot or the second shot. That's what they're gonna ask you about. Because they're not gonna ask you about the third or fourth shock because it says 4 to 10. It gives you a range. The first two are specific. So if it's on the second shock, they'll still present with those answers. If it's on the first shock, they'll present with those answers. But they're betting on that you are not going to convert to kilograms. You just need to convert to kilograms. All right? Other things they ask, I'd like to ask you about pediatrics. How hard do we push down? 1/3. So 1/3. Now our compressions are still 100 to 120. That doesn't change. All right. This is the only one that gives you the 15-to-2 ratio. So it says, if 2 rescuers pre-puberty. Everything else is 30. So if it's a true pediatric, you have 2 rescuers, 15-to-2. All right. Everything else is stale, change every 2 minutes. First shock 2, second shock 4. All right. Epinephrine still comes in the same regimen, except it's 0.01 milligrams per kilogram. Amiodarone, it's what?
5.
5. Lidocaine, it's 1. Do you see any big other changes?
No.
It goes pretty much the same. So all I'm doing is pointing out the changes. All right. Now, H's and T's, it adds in hypoglycemia. You could put hypoglycemia in the adults too. They just took it out of the adult one. All right. So, just what do you do for hypoglycemia? You give them what? Yeah. Give G10. All right. Hypovolemia, we've already fixed it. Hypoxia, already fixed it. Hydrogen ion, guess what? The dose for bicarb with an adult is still the dose for bicarb with a kid. Because it's weight-based. So you'll give more to an adult, less to a kid. All right. Hyperkalemia, if you suspect it, it's probably not going to come into play. You'll see a lot of kids on dialysis, stuff like that. Hypothermia, get them warmed up. Tension pneumo, you still dart them. Tamponade, probably not going to run. Toxins, find a reversal agent. And then thrombosis, pulmonary, coronary, make sure you go hospital PCI capability. If feasible. Can the closest hospital take care of a cardiac arrest? Yes. You always can go, but you can always go to the closest hospital if it's cardiac arrest or an airway issue. Any other cardiac stuff you've been asked that you, before we move on to a different subject? Anything you remember from registry cardiac that you were like, what the fuck?
I had them ask me, like, they gave me, like, a certain rhythm, but described it the way it was.
So it's like a word problem instead of a visual problem?
Yeah.
So if it says upright P waves, we know it's what? And it's just, they're describing it. If they say more P's than Q's, what are we dealing with? 3rd-degree block. All right? Yeah. If they say a widened QRS greater than 0.12, regular rhythm, it's B-tap. That's it. Greater than 1.
Now I seen a green stick fracture. I was like, what is that?
Really?
Then I looked it up.
Oh, yeah. It's just their bones. They're very pliable.
Yeah.
They always have green stick fractures. Pediatric wise, do you have you ever heard of Waddell's triad? I've been asked that twice. And it's an injury prediction pattern for I didn't know this on the first one, I got it right. So it's a prediction pattern for certain injury patterns that you will see with the AutoPet. So here's how I ran through it. I go, this is what else tried, and I go, and it said, and it was basically like head injury, chest injury, pelvic injury, and it had a bunch of injuries that were piled together. So I literally thought of a car, a sedan, and in my mind, I lowered myself down, and I go, now I'm a kid. If this car hit me dead on, this would probably be my thighs, this would be my abdomen, this would be my chest. And I looked up and I go, okay, probably these three. And that's how I did it. I think it was, what is it? Look, somebody look at it. Might have head injury in there.
How do you spell it?
Waddles, W-A-D-D-A-L-S.
So it says bone fracture, abdomen, and thoracic cavity and head injury.
So it's everything from here up. But that's all I did was just, I didn't know that answer. Never heard of that terminology, never heard it all. That was the first question on my test. But I looked at the answers and I go, okay, this is, what 3 injuries would a kid have that gets hit, auto pit, gets hit by a car? I just thought it through, you know what I mean? And I got it right and I saw it on the next one. Let's see here. Any other cardiac questions? Anybody got any heart sounds and stuff on theirs?
S1, S2.
S1, your love. So what? If they, the biggest one I can give you shortcut. S1 and S2 are normal heart tones. S3 means CHF. It's usually like loved up with it's CHF. And if they ask S4, it's usually stenosis of the valve stenosis, like a hardening of the valves, calcifying of the valves. And that comes before S1 and S2. All right, take a break. We'll come back and start. We'll do OB. All right. OB. All right. First off, we do kind of how I break it up. What's the pregnancy length?
36, 40, no, 30. 36 to 40 weeks.
Weeks.
40.
All right. If they give you, if they put this terminology or this acronym, okay, MP, what does that mean to you?
Last known menstrual.
Last known
Menstrual period.
normal period.
Yeah.
Yeah. If they put LN, and this is female specific stuff, but if they put LKM, I'm sorry, it's LKMP, menstrual period. Last known menstrual period or LNMP, it means last normal menstrual period or last known menstrual period. Greater than 4 weeks means what? Prego. Greater than 4 weeks equals prego. Because a normal menstrual cycle is what? 28 days, which is 4 weeks. So anything outside 4 weeks, they put that on there. LKMP or LNMP 5 weeks, we're pregnant. Now, other little deals, pregnancy vitals. Heart rate does what?
It was up, goes
BP,
down.
Yeah.
good. Remember, you have more vasculature, so the pressure drops, but you're still working off one pump. Does that make sense? We got more hose, just one pump. I always think about fire stuff, sorry. All right, as far as 2 ovaries, are women, little, just normal things to know. Are women producing eggs all the time, or are they born with a set amount of eggs? Born with a set amount of eggs. All right? You know these things are designed to get pregnant, right? These things right here in front of me. So they're designed to get pregnant. All right? Once they enter that puberty stage, all right, once a month, they will deliver an egg. And I know these aren't long fallopian tubes, but you got your ovaries and then you got your fallopian tubes. They will deliver a set of eggs to get what? Fertilized. Every month they're trying to get fertilized. All right. Now, where does the egg get fertilized at?
Uterus.
Fallopian tube. So fertilization happens in the fallopian tube. Now, to have a viable fetus, what has to happen? The fertilized egg has to drop into the uterus and connect to the uterine wall. The uterine wall is a muscle, all right? So it has to drop in there to get, like, what happens if it gets fertilized in the fallopian tube and it stays there? There you go, ectopic pregnancy. You will never hear a heart rate, never hear a heartbeat, none of that stuff, because it never made it down to attach to blood flow in the uterine wall. All right? So, your fallopian tubes, you got your uterus, muscle, down here at the bottom, the cervix where they measure dilation. All right? That's your key to, or gateway to the birth canal, right? Now, I separate stuff into first try is 0, or you could say 4 to 13 weeks. Second try, 14 to 28 weeks. Third try is 29 to 40 weeks. All right, now if I put an arrow over, that means it bleeds into the other trimesters, and this can happen. But your 2 main issues that happen in the first trimester are, we call it abortion, but you know what I mean, miscarriage, right? It's the medical term for miscarriage. All right, so you could either have abortion, or what's what we just talked about? Ectopic. All right. Abortion, signs and symptoms. Bleeding. Lower abdominal pain. Vaginal bleeding. Ectopic. What's the different sign for ectopic? One-sided. Lower abdominal pain. Also vaginal bleeding. Alright, now, usually what happens with abortion or miscarriage is, it's usually a just characterize them, but usually it's a drop in the progesterone levels. Do you know what the progesterone levels have, what their main job is during the pregnancy?
Uterine contractions?
It's attachment to keeping it attached to the uterine wall. So if you have a drop in progesterone, that's when it separates, loses the blood flow, and then you get the miscarriage. All right. Now, what are they? I don't think they're gonna ask you like that. But so abortion, you keep going into the second trimester. Do you know what like the kind of goal like there's different goals that you hit during pregnancy? You have a kid? Anybody? Nobody? Yours? First class?
She had to go, but.
Oh, okay. All right. There's benchmarks we hit. First benchmark is, well, you get the pregnancy test back. Now, what does that pregnancy test measure? An increase in hormone levels. And hormone levels will start going up through the roof. All right. Second deal is to get a sono and a heartbeat. Usually that's anywhere from 8 to 12 weeks. But you go do that, you get the heartbeat, everything, and then they have other tests that they run, like they'll run a Downs test, they'll run at 18 weeks or something like that. And there's some scary parts, but your goal is to make it, when you get to about 23 to 24 weeks, even if you went into labor, you could still have you could basically have a successful pregnancy. That would be like delivering a 1 pound kid. I know 2 guys at our department that they went in, induced, had a lot of problems during the pregnancy, and they delivered a baby at 24 weeks. Spent a lot of weeks in the NICU, everything like that. But usually 24 weeks is like, hey, I can breathe a little bit. Like if something happened when we went into labor, we could still have a kid. 21, there have been stories about earlier, but the breathe easy deal is like the most common, like, hey, I feel like we have a good chance of survival, is 24.
Yeah. It's just impressive there.
But Embry's daughter was a 23-week baby. Yeah. Little bitty. And she's a pistol too. All right. Now, we get into second trimester. We can start having other issues. All right. Now, ectopic, you go get a sono. There's never a heartbeat, never anything. We just got the elevated ECG levels. That's it. We didn't lose anything. You can't tell a woman that. I promise you, it's treated just like a death. All right. But now we deal with these patients. Do you know the difference between sympathy and empathy?
Sympathy is
No. Sympathy means we have a shared experience. Can I sympathize with you about your period pain? Because I've never had a period. Can I empathize with you? Yeah. I can feel for it. I can say, I'm sorry, I know you're in pain. I can empathize with a lot of patients, but if I've never gone through that experience, I can't sympathize. Has anybody here lost a dad? Nobody? Has anybody here lost a grandparent? Okay, so y'all could sympathize with each other over the loss of a grandparent. You know, if you were dealing with a patient that lost a grandparent and you worked with them and had to call it, and you can sympathize with them because you have a shared experience. Empathy is, I can still feel sorry for you, or I can feel your pain, but I've never experienced it before. I don't know if they'll ask that. It used to be old school stuff they'd ask on EMT. Okay. All right. So now we get to second trimester issues. Second try, that's when we start talking about preeclampsia. We talked about that earlier with the PIT. All right. BP greater than 140/90. In real life, if you have 2 doctor visits where your BP is greater than 140/90, you are diagnosed as preeclampsia. On this test, anybody that if they are pregnant and they have a blood pressure greater than 140/90, you can consider them preeclamptic. Alright? Now, these signs and symptoms are just due to the increased blood pressure. If you have high blood pressure, people typically have a headache.
Yeah.
There we go. Can elevated blood pressure give you blurred vision?
Yes.
Yes. Alright, now another sign or symptom could be proteinuria. You don't know that unless you can do a piss test on it. And another one would be fetal edema. Just to give you an example, my wife is preeclamptic. My wife is 4'11", weighs about $110, maybe $105. Alright. Alright, $110, $105, and she gained about 50 pounds of water weight with my son. She delivered at like 203. She'd probably kill me if I told you that. But anyway, she delivered my daughter at 148. She delivered my son at 203. So that's a lot of water weight. So here's what happens. It has to do with, what did I tell you the kidneys control?
Volume pressure.
Volume of pressure. How they measure, it's a deal with renal damage. So how they measure how much renal damage is occurring or how worse the preeclampsia is going is they will collect your urine for once a week throughout the pregnancy, and they will see how much protein you're spilling into it. If you're spilling more protein, you're having more kidney damage. If you're not spilling protein, you're stabilizing. But they will test your pressure, they will test your blood pressure, they will test you for the edema and all this other stuff. But the protein is to measure how much kidney damage is happening. More kidney damage, increased blood pressure, increased fluid retention. She was able to make it through without going on any bed rest or anything like that, but she gained a lot of weight. All right, but you get the fetal edema, proteinuria, blah blah blah. Now, what do you do to treat that? Can you treat that with MAG? Yes, you can. What does MAG do? So MAG does a couple things. Smooth muscle relaxant, but it also helps out with, it has some anticonvulsant properties. Small, but it does. So if it goes to eclampsia, like that. All eclampsia is when they start seizing. All right. Seizure, you can give both MAG, you can go MAG plus a benzo to take care of the seizure. Alright?
Would it be the same dose for MAG
Yeah, you can give high dose MAG.
for both? Both going to be taken.
Give the 4. Alright? Now, here's the kicker with these two. These can go up to 12 weeks postpartum. You'll find some different literature that might say 6 to 8. I don't know if it's switched. When my wife did it, she had to take blood pressure medicine for 12 weeks postpartum. So if you had a female, 6 weeks postpartum, seizure, and no history of seizures, you can assume this is an eclamptic seizure. It just means you would step up and bring MAG first. Bring MAG before you do the benzos. Usually we do benzos to stop seizures. In this case, do MAG first. All right. So whenever you get a patient that's pregnant, I want you to pay attention to their vital signs. Because if it says 160/80, guess what? We're preeclamptic. All right. Now, third try is when you get your. What do you think we're going to get now? What two deals?
So then it's a pre.
Previa and abruptio. What is previa?
Everything is bleeding.
So here is previa. Placenta, baby. It's implanted over the uterus, over the cervix. You can have a partial previa where part of it's over the cervix, or you can have a full previa where it's blocking the whole cervix. This is a guaranteed C-section. This is why we don't see a lot of them. And because there's so much prenatal care now given to even people without insurance, like their health clinics and stuff like that, they know about this. All right? So previa is usually a known deal. The bleeding with previa is actually worse. All right? So I don't know if you know this about women, but during the last little bit, the last couple of weeks, they actually start to dilate early. So by the time they go into the doctor and they're ready to deliver and everything, they could already be at 2 or 3. So that small little dilation causes a little separation, and it causes some bleeding because the placenta is right there. It's not a ripping and tearing, so there's no pain. So this is the painless bleeding. But there's actually more external vaginal bleeding with this. You want to make abruptio real easy? Abruptio is always going to be a trauma question.
Mm-hmm.
We don't usually get a spontaneous abruptio. You have to have a shearing force with this. So what happens here? Draw a better deal. So you actually have it. What happens here is you can get a partial or full abruption. That is a tearing away from the ball. If you have a full abruption, the baby is essentially on its own. It's dead because there's no blood flow. They get their blood flow from the placental wall. All right. A partial abruption, it's like they're in shock. All right, this is a imminent delivery. We need to take care of this. All right, this is the code 3. Get to the hospital. They're going to do a C-section right there in the ER. Seen it once. But this is going to be an MBC, 32 weeks pregnant. Painful, less bleeding, external bleeding, more internal bleeding inside the uterus. But very painful because there's going to be a shearing force that ripped it away from the wall. All right, and then other scenarios. This could actually be from a fall down the stairs.
Uh-huh.
And they typically fall down the stairs in the 3rd trimester. Then what?
Mhm.
They can't see the stairs. They're going down blind. So a fall down the stairs, a fall, even as simple as a fall, I've seen it on this test, a fall in the shower.
Yeah.
Some kind of abrupt shearing force. I don't know if you've ever fallen in the shower. I would have thought it would be like no big deal, but I took a fall before vacation last year because I didn't realize our spare bathroom was so slick in the tub, and I straight up landed butt crack on the edge of the tub deal, and I was like, am I going to bust my pelvis? And I was like, I'm about to have an old person injury. Luckily everything was okay. Like my daughter even said, she came to the door, she's like, is everything okay? I'm pretty sure the house shook. But I went toes up, full on fall. So I can appreciate that's a good enough fall to cause an abruptio placenta. So fall in the shower, I've seen it as a fall in the stairs, and used to be I would guarantee you it's going to be a side impact or a head-on MBC. All right, they're going to be screaming, bloody pain, and there's not going to be a lot of blood showing, but there will be blood, and it's going to be a lot of internal. You might feel here and be like rigid lower abdomen, but this is painful bleeding, trauma scenario. This is a guaranteed C-section. You don't see a lot of external bleeding.
What do we do for a abruptio?
Abruptio?
Like,
Code 3 is at the hospital.
That's it? That's it. Okay.
treat them for shock, but code 3, get them to the hospital. You're talking about how many minutes that baby is separated with blood flow. So the quicker you get there to the C-section, better it is.
Any,
Recognize it, that's the big deal.
What is it, whenever the cord snaps? Breaks, whatever, it's still inside. Oh, I don't know. I had a patient and she like came home with blood out because the baby was delivered, but the cord was snapped and not coming. So it shot back inside.
Oh, okay.
The midline.
Until the placenta fully delivers?
Yeah.
It's the same lack of blood flow, loss of blood flow until the placenta delivers.
Oh.
But it's, yeah, you gotta get a hold of that cord. But you just gotta, you basically gotta induce you gotta get that, we can give stuff like Pitocin. So what stimulates uterine contraction is oxytocin in the body. They give the same stuff synthetically to initiate contractions, which is Pitocin. And there's actually studies going that they want us to start giving Pitocin in the field to tampen off bleeding afterwards. But if I was gonna treat that, I would try to give Pitocin to stimulate contraction and get rid of the placenta. And then also tampen off bleeding. But I've actually never heard about that.
Right.
No.
can we give any pain management?
Huh?
Pain management? Pain management for the stroke.
I would concentrate more on food and trauma care, taking trauma care. Not so much I would concentrate on getting there as quick as you can, sticking some IVs in, getting some fluid resuscitation. As much as I could. The other one that can happen in the 3rd trimester, and this deals with trauma as well, is, have you ever heard of this? Supine hypotensive syndrome?
Yeah.
Yes.
This is the unit fever.
Roll to the left.
Email me. You'll see them.
Don't.
I can't pronounce the easiest thing.
I'm gonna smack you, Dad. Chuck it at your face. Shave?
No.
Drugs.
Don't breathe it out.
Oh, man. I'm done.
Oh, that's that. Did y'all ever go to we had one,
Okay.
we went to like MCA Hamilton or something like that?
Yeah, been there.
They had a Chick-fil-A sandwich 4 days a week. I
Yeah.
got like 3 of them. Smoked one went back.
I'm surprised I went to MCA. Cause they hate that place.
Oh, yeah. Okay. You know, every time a patient be like, I go to medical city, and they're like, whoa, we ain't going there. Pretty much wrong. Some guys are good straight, no, we're not taking you there. We're going this, and they're like, okay, fine. They don't matter as long as you get signature.
That's true.
Because it's 45 minutes away.
They have a reason, that's why. I think it was because they got into it with some nurses. They were like pediatric CPR, and I forgot what the nurses were asking. They were like, when.
What's the
they
blood
go
sugar?
down, they want like a specific, oh, when they start CPR, work on, we don't know. And she just kept insisting. And
Some of the nurses,
so that's why I hate it.
I hate the nurses don't listen to your report, and they ask you questions like that.
I just said that.
Lying.
I told you.
What's the blood sugar?
What's the EMS room, man? Other than
That,
energy drinks, protein shakes,
Protein bars.
candy bars,
Uncrustables,
Uncrustables,
chips.
Hot Pockets,
Mm.
little pizzas,
Got it.
everything.
Meth
Vegetables.
is like, meth is alright.
Yeah,
I can eliminate like every time.
I don't want to say.
Hey, ice cream. Get that freezer. Snickers.
Ice cream bars.
Oh, I love that.
That's very good. So, what to take out of there?
We gotta call it tonight. We're gonna go to Peter Fries.
Yeah. Something you call it a shopping cart. And bring the stretcher right next door and just put the
Oh,
bush
yeah.
out top and take it for the whole station.
Yeah, if you go to Peter, you better bring Bragg. Like food for everyone.
Oh, yeah.
Oh, yeah.
Oh. Alright, so. Alright, market that we're gonna leave here, and we're gonna pick up with, prolapse cord, nipple cord, we'll pick up with actually pregnancy, or delivery. We can do that in like 15 minutes, but we'll do all the nipple cord,